Good afternoon. Welcome to our annual DMH Research Centers of Excellence Conference. This conference is co-sponsored by the two research centers funded by the Massachusetts Department of Mental Health, the Massachusetts General Hospital Center of Excellence in Psychosocial and Systemic Research, and the Implementation, Science, and Practice Advances Research Center, or iSPARC, at UMass Chan Medical School. I'm Khoury. It's my pleasure to welcome you. I am the director of the Massachusetts General Hospital Center of Excellence, and it is a privilege to co-host this conference today with Dr. Megan Kelly, a clinical psychologist, researcher, and the director of iSPARC. Before we get started, let me just review my disclosures. And here is our agenda for the day. Our conference topic, as you know, is collaborative statewide approaches to improving care for individuals with mental health and substance use challenges across hospital and community settings. Today's presentations will highlight innovative programs addressing key challenges. These include managing aggression through multidisciplinary collaboration, shown here, and that will be followed by a panel discussion offering perspectives from the field. Next slide, please. Then we will discuss expanding access to medications, strengthening alternatives to incarceration, and approaches that promote recovery, community integration, and healthy aging. Let me review a few housekeeping issues for today's conference. So this conference is being recorded, and this recording will be made available following the conference on our websites. We'll put those websites in the chat so you have them. Also, links to the recordings will be mailed to all registered participants. Live captions are available. The icon to enable them is in the control panel at the bottom of your Zoom window. You'll see that button here. If you have any technical questions during the conference, there's a phone number that you can call that will be in the chat. You can also put your question in the chat. ASL interpreters are available and will be automatically spotlighted throughout the conference. Please use the Q&A function at the bottom of your Zoom screen to send questions to the presenters. If you do not see the Q&A, please click the More button shown here. And in the chat, we'd love it if you would introduce yourself to the group, share resources at any time, and feel free to chat with other attendees. But please do remember to put the questions in the Q&A. It's a great idea, too, to put the questions as they come up for you and not wait till the very end of the presentation. All attendees will be muted and the cameras are off for this conference. Next, please. Continuing education units, we'll review at the end. You may want to take note of this email here for any questions about CEUs in particular, but we will have CEUs for psychologists, nurses, social workers, occupational therapists, and licensed mental health counselors. Next slide, please. The requirements for CEUs are pretty similar to CMEs. You do need to join the conference with your full name displayed. You have to attend the entire conference, and you need to complete an evaluation upon conclusion of the program, please. We will send a link and QR code to the evaluation near the end of the conference. It will also be shared in a follow-up email. Next slide, please. Here are the requirements for CMEs. And you may want to take note of this email, which is for questions related to CMEs. Next slide, please. Fantastic. So we would like to spend a few moments thanking the people who prepared for this event today, our supporters and our speakers. So on behalf of both of our centers, we want to express our immense gratitude for the support we've received from the Department of Mental Health. And in particular, we want to thank Dr. Margaret Geyer, Director of Workforce Development and Research, and Dr. Imam Saleh, Deputy Commissioner for Clinical and Professional Services, whose invaluable guidance helps ensure that our work aligns with the strategic priorities of DMH, benefits the residents of the Commonwealth, and improves mental health care throughout our state. I would like to acknowledge the combined efforts of our team members and the team at iSPARC for all of the planning and cooperation that went into today's conference. We are grateful for the continued partnership between our centers. Thank you as well to our wonderful speakers and panelists, to our leadership in the Mass General Brigham Department of Psychiatry, especially our extremely supportive, kind, and accessible Chief, Maurizio Fava, and our close MGH colleagues in the Division of Public and Community Psychiatry, the Center for Addiction Medicine, and the Psychosis Clinical and Research Program for their steadfast support and shared commitment to advancing community-based research and innovation. Our Mass General Hospital Center of Excellence continues to grow and evolve, building on a strong partnership with the Department of Mental Health and an ongoing commitment to improving systems of care for individuals, families, and communities coping with mental health and substance use challenges. Thanks to an extraordinary team, including the essential contribution of people with lived experience of mental illness, the scope and impact of our research, implementation, and quality improvement efforts have continued to expand with meaningful progress in strengthening care across hospital and community settings. Now let me turn it over to Megan, who'd like to say a few words of thanks as well.
Thank you, Khoury. I would like to begin by expressing our appreciation to everyone who contributed to our efforts this year, particularly Khoury and the MGH team for their tremendous efforts in organizing this year's conference. Thank you for the extensive planning that went into today's event. I also appreciate the evolving partnership between our centers, especially in advancing systems change, which is so well represented in today's presentations. iSPARC promotes the recovery and quality of life of individuals with behavioral health conditions across the lifespan. We partner with individuals, support networks, and community groups to conduct innovative research, provide implementation support, and disseminate promising and evidence-based practices. Our mission is to improve behavioral health systems and services and advance public knowledge. Our thanks also go to the committed iSPARC faculty and staff for their important contributions to advancing behavioral health care in the Commonwealth and beyond. We are especially grateful to the UMass Chan Department of Psychiatry and Behavioral Sciences for their ongoing support of iSPARC. Many thanks to our chair, Dr. Kimberly Yonkers, whose outstanding collaboration helps us achieve our goals in behavioral health, research, and implementation support. I would also like to especially thank the iSPARC communications team, including Marsha Ellison, Dee Logan, Robin Tasca, and Jonathan LaRue, as well as Holly St. Jean, for their behind-the-scenes work on this conference, including getting the word out about the event and for making sure what we do is accessible to others. Many thanks to Marsha Ellison and the iSPARC Technical Assistance Team for their excellent work at iSPARC, which will be highlighted today. Related to our technical assistance partnership with DMH, we are grateful to the Office of Inpatient Management for their collaboration on the inpatient aggression management work we will discuss today, including Mary Louise White, Director of OIM, Jonathan Carvalho, Operations Manager, David McGarry, Medical Director, Julianne Flynn, Clinical Training Specialist, Kara Sousa, Informatics Nurse, and others at DMH, including Christine Goldrick, Senior Director of Strategy, and Alex Khoury, Strategy Manager. Thanks. I'll turn it back to Khoury.
Thanks so much, Megan. Now we are honored to recognize and welcome Emily Bailey in her new role as Commissioner of the Massachusetts Department of Mental Health. Commissioner Bailey brings extensive experience from her leadership at MassHealth, where she played a key role in advancing major system transformation to improve access, quality, and coordination of behavioral health care across the Commonwealth. Most notably, she was instrumental in the development of Massachusetts' network of community behavioral health centers, CBHCs, a landmark initiative designed to provide timely, community-based access to mental health and substance use services, including urgent and crisis care. This work has significantly expanded access points for individuals and families, reduced barriers to care, and strengthened the state's behavioral health safety net. In addition, her contributions at MassHealth have supported broader efforts to integrate behavioral health with primary care, enhance care coordination for high-need populations, and promote equitable value service delivery. Commissioner Bailey's leadership and vision will shape the future of behavioral health care in Massachusetts for years to come, and we are delighted to have her help set the stage for today's discussions.
Thank you, Khoury. Good afternoon, everyone. I'm so pleased to welcome you to the 2026 annual conference of the DMH Research Centers of Excellence, which we call COEs. It's incredible to see so many people joining us today to focus on building solutions and breaking barriers in mental health, which you just heard has been so critical to my work and I know is so critical to all of yours. The Centers of Excellence at Mass General Hospital and UMass Chan are such essential partners in advancing DMH's mission. Among the many things that DMH asks of the COEs, two priorities are especially important and frankly have been so exciting to me as coming on as new commissioner, learning about these partnerships. First, relying on the centers to facilitate the rapid translation and dissemination of research findings, not just for academics, but for providers and for people that we serve and for the community. Because as we all know, research really only matters when it facilitates change and when it reaches the people who can use it in day-to-day work and it informs practice in real time. And second, DMH asked the centers to help shift the culture and operation of the research itself, which is also incredibly exciting, which means actively engaging the people who will ultimately use and benefit from this work. So that's DMH's staff, our contracted and operated programs, consumers and service users, family members, stakeholders. When research is shaped by those voices, it becomes both more relevant and more rigorous. Today's presentations are just so incredibly exciting. They illustrate the ongoing commitment and success of both of these centers in advancing these priorities. You'll hear about research developed in partnership with people with lived experience, research that immediately informs current services and strengthens the work happening across our system every day. You heard a little bit already about the topics that will be covered. I'm sure that you've read about them, but they're just so timely and so relevant. Exploring collaborative ways to manage aggression in the hospital setting, exploring how to expand medication access for people living with serious mental illness, hearing about alternatives to incarceration, and learning about positive aging. I hope you leave today with new actionable information to inspire and improve your work and also leave feeling energized. I know it's a huge commitment and time out of your very busy schedules to make an afternoon available today. So I hope you leave here wanting to know more and energized and informed. The websites are made available to you, I think, in the chat, but please do visit the websites of the COEs and or DMH, where you can find annual reports, full scope of work, more information if you'd like to learn more. And then finally, thank you to Khoury and Megan for their leadership and for this conference today, as well as the DMH leadership team. And finally, thank you to all of you for your commitment to advancing behavioral health across the Commonwealth, for caring enough and thinking out of the box enough to be here and to learn about these research efforts and thinking about how we can continue to challenge ourselves to improve the service delivery system. And with that, enjoy the conference.
Thank you so much. I'm now going to turn it over to Dr. Marsha Ellison, professor of psychiatry and behavioral sciences at UMass and director of iSPARC's Technical Assistance Program. She will introduce our next session.
Sure will. Thank you very much. Pleasure to be here with everyone. I'm going to introduce this first presentation, a collaborative approach to managing aggression in the hospital and the community. None of the presenters that I'm going to introduce have disclosures to present at this session. Could you go to the next slides, Ben, please? And the next. Thank you. So I am the director of the Technical Assistance Program at iSPARC. Dr. Megan Kelly will be introducing the listening sessions portion of this presentation. She is director of iSPARC at UMass Chan Medical School. This will be followed by Ms. Julianne Flynn, who is in the Office of Inpatient Management and a clinical training specialist. She'll be presenting on the strategic plan to manage aggression in the hospital and the rollout. And this will be followed by an evaluation of the pilot of that rollout. First, we'll hear from Mr. Alex Khoury, who is a Senior Strategy Manager at the Department of Mental Health. And he will present the quantitative results. I will present the qualitative results following Alex. And then we will conclude with a brief presentation by myself about how these principles of managing aggression were translated into a training module for ACCS providers in the community. Not here on the slide, but last but certainly not least will be a panel presentation by members of the 3 units who participated in the pilot, who will be able to talk about what actually that felt like and meant to them. And this panel is organized by Ms. Julianne Flynn. So with that, we will turn it on to our first presenter, Dr. Megan Kelly.
Thanks, Marsha. So it is a pleasure to talk with you today about our work on the facilitated listening sessions that we held with staff on the inpatient units in partnership with DMH's Office of Inpatient Management and the MGH-COE. Next slide. So to understand how to best intervene on the inpatient units, we partnered with DMH and the MGH-COE to hear directly from inpatient staff about their experiences and thoughts. We wanted to learn more about the nature and frequency of aggressive behavior from patients, as well as understand what practices the staff thought work best to manage aggressive behavior, so to hear directly from them. And we also asked about what practices that staff believed were ineffective and the supports that they believe were needed to improve the management of aggressive behavior. Next slide. So we developed questions for these facilitated listening sessions in partnership with DMH and the MGH-COE. We reviewed the literature to understand the best questions to ask, particularly on predictors of inpatient aggression to inform our questions. And questions focused on changes in the level of patient aggression over the past few years, get an understanding of that, and the level and types of aggression that were experienced. We asked staff about the factors that they believed contributed to patient aggression, as well as strategies that helped and were not helpful. And then we also asked staff about thoughts on recommendations that we could make. Next slide. So iSPARC and MGH partnered to conduct these sessions. iSPARC conducted 17 sessions with 89 staff at the Worcester Recovery Center and Hospital, at Taunton State Hospital, and the Recovery Addictions Program at Taunton. And the MGH-COE conducted 12 listening sessions with 84 staff at Tewksbury Hospital, Shattuck Hospital, and Fuller Hospital. Next slide. Each listening session lasted for 60 minutes. They were led by a facilitator, and someone was taking notes on the side. Facilitators also taking notes. Sessions were held virtually and in person, whichever method was convenient for the staff. No sessions were recorded. Notes were taken by hand or by laptop. And we had a diversity of staff interviewed, including mental health workers, psychiatric nurse practitioners, psychiatrists, psychologists, nurses, social workers, rehabilitation staff, occupational therapists, peer specialists, and recovery coaches. So quite a diversity of personnel. Next slide. So we asked staff what factors, actions, or practices work well for preventing or managing aggression and hostility. And they told us that offering more recreation and therapeutic options for patients is helpful. They discussed the importance of de-escalation and early intervention, as well as maintaining problem behavior lists. They believe that stronger staff-patient relationships and the consistency of staff was critical, so staff getting to know the patients and understand them, as well as stronger communication and teamwork across the staff, so good team cohesion. And they mentioned the importance of having adequate staff-to-patient ratios to be prepared, and specialized training for staff that's matched to the type of patients on their units. Staff also mentioned holding patients accountable for their behavior and providing consistent training on restraint policies. Next slide. So staff thought that several things were ineffective in managing aggressive behavior, including a mismatch of patients to units or hospitals. The acuity of patients in refractory conditions is also a challenge. Having ineffective restraint policies, being understaffed, staff who were afraid of responding to incidents, lack of structured time on the units for patients, and a lack of consequences when patients were assaulted, which staff believed reinforced the behavior. Next slide. When asked what support staff wanted to manage aggressive behavior, they mentioned having more support and communication from administration, having more staff and training, clear policies about how to respond to aggressive behavior, personnel incentives, and addressing more complicated systems issues like court processes and a lack of community resources. Next slide. So staff recommended several strategies based in their experience that could be of help. They encouraged getting input from staff at all levels when new policies for managing aggressive behavior were developed, as well as the development of training and the interventions themselves. They wanted leadership to be present more often, including compassionate debriefings and responses when assaults occur. And they wanted to continue to have procedures for identifying triggers and characteristics of people who might be aggressive and to have accessible patient plans on every unit. They wanted to promote staff cohesion and implement ongoing training around restraint procedures and accountability, positive behavioral supports, the use of BRACET, which is a violence prediction instrument, and MANT, which is an evidence-based training program designed to reduce workplace violence, which will be discussed by my co-presenter, Julianne Flynn, today. All right, so I'll turn it over to Julianne.
Thank you, Megan. And good afternoon, everyone. I am Julianne Flynn from the Office of Inpatient Management, and I am so pleased to be here to discuss the implementation of the Department of Mental Health's Aggression Management Pilot. The information presented earlier by Megan provides context on the factors that led to the adoption of a targeted and comprehensive approach to manage aggression. OIM, or the Office of Inpatient Management, identified 3 pilot units within the different state hospitals to evaluate this initiative. So the pilot project focused on validating and reinforcing strategies for the proactive identification of aggression using evidence-based tools, enhancing management techniques, and identifying leading practices for the treatment of violence and aggression. Next slide, please. So our goals. Our objective was to address aggression by reinforcing standard, consistent practice across shift and integrate the clinical team more intentionally with the direct care staff, augment the clinical approaches utilized within the milieu, provide external consultation with identified subject matter experts with the entire team to inform clinical practice in the areas of psychopharmacology and substance use as they relate to the incidence of violence. We worked very hard to create and reinforce clear pathways of communication. We examined current practice and workflows to create efficiency and meet required standards. We provided practical on-the-job training resources for staff, and we defined foundational training elements and provided an integrated and phased approach to reinforcing and integration of these concepts and existing tools. We also identified and addressed gaps in knowledge and practice among direct care staff to enhance safety and effectiveness within the work environment. We also established a clear link between policy and practice to encourage compliance, uphold safety standards, and ensure consistency throughout the organization. Next slide, please. So our core elements. We adopted a phased training approach across shifts to enhance team development, foster effective communication, and establish foundational knowledge within the unit. Our training integrated scenario-based learning, directly connecting policies to practical application. By utilizing real-time scenarios, we facilitated discussions on utilizing existing tools to identify indicators of aggression or safety concerns, manage situations promptly, and ensure ongoing support. Following unit training, treatment teams associated with this unit also received training. The training included the direct care staff to emphasize collaborative practices and an integrated approach to managing treatment teams and interventions. Any unresolved issues or inconsistencies in practice that lacked clear resolution were escalated from the unit right up through leadership. Ongoing practice-related discussions were prioritized and addressed promptly. Additionally, scheduled meetings with OIM and pilot units were held to ensure a consistent feedback loop and continuous improvement. Next slide, please. So our phased approach, our phase 1 session was all milieu training, and they were conducted as collaborative discussions guided by policies, facility workflows, patient demographics, staff demographics, and existing milieu tools. This collaborative approach helped identify and address inconsistencies and ambiguities through the internal communication structure and the OIM pilot meetings. Specific issues addressed included shift reports, treatment team meetings, patient visit policies, staff roles, contraband concerns, incidents of aggression and assault, admission assessments, observation levels, safety checks, PRN medication use, and medication order availability, particularly during off-shift hours. A focus of discussion consistently incorporated the various milieu tools already utilized, such as the Brosette mentioned earlier, elements of MANT that include radar, huddles, the use of the crisis cycle, as well as our safety checks and levels of observation, and then the application of how they work together and complemented one another to create a safe environment. Situations and patients on that unit were discussed in this context to improve understanding and competence. We incorporated facility policy, Joint Commission, and CMS licensing standards, DMH regulations, and their application into all aspects of training. In this way, accrediting information was woven into the review of hospital procedures and workflows. When unit process conflicted with policy, unit staff and facility leadership and OIM were included in communication and notified to address inconsistencies and improve practice. Next slide, please. Substance use. So that was our phase 2. A gap in knowledge for many staff is in the area of substance use. Milieu training focused on a few key areas: substance use awareness and emerging trends, with an emphasis on the identification of commonly used substances and abused substances, behavioral indicators of use, withdrawal, what harm reduction is, and post-acute withdrawal considerations. The focus for staff on the units was what this looks like on the unit and how to communicate around this. The resulting discussion identified the need for change in statewide in some of our existing policies. There's an identified need and change in our admissions and our visitors policies, and we also developed standardized protocols and workflows to increase safety and decrease potential for medication diversion. External consultations proved to be highly valuable with all staff, including clinical, medical, and direct care personnel participating. The consultations were helpful in refining clinical approaches, reinforcing leading practices, and increasing awareness of the intersection between substance use, mental health, and aggression. Next slide, please. So 2B, we added in this additional phase, and we added this in for milieu staff in order to reinforce and train on the interconnection of mental health and substance use and the implications for unit approaches and interventions. This way, we were able to integrate the information from the first 2 phases in a practical manner to reinforce learning and improve intentional interventions and engagement with patient on the units. Next slide, please. So clinical training and consultation. Consultation by subject matter experts in the area of aggression and psychopharmacology and aggression and substance use was held virtually for initial training subsequent to in-person unit and patient-specific consultation. External consultations complemented the classroom content, adding additional perspective and expertise to support the teams in decision-making and intervention strategies across the disciplines. This collaborative and supportive approach enhanced staff engagement and strengthened teamwork to reinforce the identification of precipitous violence, techniques to manage violence, and treatment strategies to address over time. Next slide, please. DBT was implemented and approached differently than the other components or phases. We actually started with a statewide approach to provide opportunities for all facilities and all units to benefit from DBT, dialectical behavioral therapy. What we did, We provided 2 intensive DBT trainings about 6 months apart, and each facility sent selected team of individuals to intensive DBT training, and then those individuals were tasked with developing facility-based implementation teams. A statewide virtual skills training was also implemented to provide an overview of DBT skills and how skills can be utilized within treatment, including the milieu, and that was provided to staff across DMH. Ongoing consultation by external subject matter experts has been provided to each implementation team at each facility, as well as site visits, on-site training targeting DBT skill acquisition, and a 7-week DBT for individual therapy, which was held virtually and offered statewide. We are developing internal capacity to provide intra-facility consultation and support. Our next step is to continue to expand DBT skills into the milieu so the direct care staff develop competence in teaching and reinforcing selected skills on unit to promote patient skill building and the capacity for self-regulation. Next slide, please. So in summary, the pilot program was successful on so many different levels. Staff engagement and commitment to working together differently and with more intention has contributed a great deal to the success of this. Communication pathways that are inclusive of leadership and direct care staff and everyone in between has led to more practice change and consistent application of these techniques and a decrease of assault and aggression on the units. The pilot program promoted transparent and open communication while fostering a culture of trust and continuous learning. We integrated existing tools and enhanced communication pathways to improve clarity and operational efficiency. We ensured accessibility by offering sessions across all shifts and validating staff contributions to strengthen engagement and morale. We actively gathered feedback to identify leading practices and opportunities for improvement. We provided essential resources to support team success and proactively address potential barriers through collaborative problem solving and strategic planning. Thank you very much. Now I hand it over to our next presentation.
Hello, everyone. Hi. Thanks for the tee up, Julianne. My name is Alex Khoury. I'm a strategy manager at DMH and was involved in this project primarily in the capacity of assisting with the quantitative evaluation of the interventions that Julianne just described. Those of you involved in quantitative evaluation here will know that that can be a very fun task or a very grim task, depending on how things go. In this case, it was a pleasure to be involved. And with the importance of this as a pilot, we really wanted to see how things shook out in the numbers before and after. So if you could advance to the next slide, I'm going to use a few minutes here to summarize the results of this pilot quantitatively, and you'll get to hear from our staff directly about their experience in the panel after, and also hear from some qualitative interviews with staff that were conducted. So the top line is that this pilot, the quantitative data from it, showed clear and compelling evidence that it was impactful. We're going to get into some of the trends as we go through, but I wanted to start with a high level stats. When we compare critical stats for these 3 pilot units at the first month of their participation to the last month, and we average across them, we see signs pointing in the right direction, and in some cases, dramatically so. We'll be looking at 3 primary measures. The first is Brosset score, which Julianne mentioned earlier, but for those who don't know, the Brosset is a scoring system for indicating risk of patient aggression. It's essentially a checklist of 6 questions. The more are answered yes, the higher the score is, the higher the indicated risk of aggression. So that's an indicator of an aggression risk. We also looked at aggression and assault incidents across these pilot units, and we looked at use of restraint and seclusion in the pilot units. So as I mentioned, when we compared the first month to the last month in each of these pilot units and average across them, we see that the incidence of high Brosset scores dropped 73%, incidence of aggression and assault dropped 62%, and incidence of restraint and seclusions dropped 42%. And this generally holds up when comparing to the counterfactual of the rest of the facilities, how things looked. This drop is still maintained. So we'll get into some of the details by unit. Anytime we're looking at data across these units, we're always going to say, okay, patients have been admitted in this time, discharged. There's always some nuances as we're interpreting. But when we look at the average across all three units, signs are pointing in a very clear direction. Another interesting point that I want to introduce at the beginning, Julianne mentioned the variety of phases of this project. I've sorted them for the analysis into two, what we could call the unit staff training phase. That's the interventions that Julianne discussed, that phase 1, phase 2, that really focus on the unit staff, milieu management, and then the clinical training phase. Those were the clinical trainings and the clinical consultations. So these happened in sequence, one after another, as Julianne introduced. And what we see when we look at the data is that some of these pilot units saw a sharp decrease during that unit staff training phase, one of them in particular. One saw a sharp decrease in the clinical training phase. And for the last unit, they were really delivered close up together. So we see them happening at the same time. But at a high level, the point I want to make here is that it seems like different elements of these interventions were impactful for different units. So different units saw different elements of the interventions have the most efficacy. Okay, if we could go to the next slide. We'll start with the data for Brosset scores for the Worcester pilot unit. And what you're seeing mapped here in the gray line is the number of times a high Brosset score was recorded on the unit within a given month. Brosset scores are recorded multiple times, so the same individual could have a high Brosset score today and tomorrow. So this is the total number of times a Brosset score was recorded, and it was at 3 or higher out of 6. We just drew a line there and said how many times did individuals on the unit have a high score in that month. And you can see a timeline. Month is on the x-axis here, and we've used these vertical lines to divide it up. Everything to the left of that dotted vertical line is the unit staff training period, and to the right of that dotted line to the solid vertical line is the clinical training and consultation period. So what you can see from this visual is that Brosset scores really dramatically decreased in the transition from towards the end of the unit training period into the clinical training period. Next slide, please. Similarly, as we're looking around that same timeline, we can see a decrease in aggression and assault incidents starting at the beginning of the clinical training period comparing to the end. You can see a gentle increase leading up to that point. But the point to make here is when we compare this counterfactual to the rest of the facility, this maintains as a decrease relative to trends in the rest of the facility, which were consistent with that small incline over the same time period. There were no trends for the Worcester unit in restraint and seclusion, so no major differences to report there from beginning to end. Next slide. The next, we'll look at the Fuller pilot unit. This is the one we originally had a different pilot unit participating in the pilot, but we switched to include this unit later on. So they received all the training in a more condensed period between March and June. So they're not separated out into two phases here, but the point to make, it's clear, you can see with the dotted lines here, a really sharp decrease in those Brosset scores from the beginning to the end of the pilot period. Next slide. Similarly, a very sharp decrease in aggression and assault incidents. Of course, March is a clear outlier here, which happened to be the start month. But even if we're comparing to the next month, you see a strong decrease, 70% decrease from April to June similar trend if we were to compare to February. So a really clear and compelling decrease in assault and aggression incidents here. Next slide, please. And similarly, a decrease in utilization of restraint and seclusion over the course of the month for this pilot unit. We can go to the next slide. So reviewing the same indicators for our Taunton pilot unit, here you see the Brosette score decreased during the unit staff training phase and maintained at that lower level through the clinical training. Note here, because of the particular mix of patient population needs, this unit didn't participate in all of the expert clinical consultations to the same degree as some of the other units. But nonetheless, you see those unit staff trainings appearing to have an impact here, and that impact sustaining. Next slide. Same very clear trend from the unit staff training period, decrease in aggression and assault incidents that maintained through the clinical training period. And one more slide here. See the same decrease in restraint and seclusion utilization over this period. So what I want to say in summary here is, you could point to specifics on these units, like that outlier month, like who was admitted or discharged in a given month. But all signs in general across these units point in the same direction. And when we average it up across the units, when we compare it to what was happening across the rest of the facilities, most of these trends, again, hold up the same way and show all signs pointing in the same direction. I'll also add, and I'll give Kara Souza, who's on our panel, credit for this. She ran the numbers and sent them to me, but these results, you'll notice this ended in June of last year that we ended this formal evaluation period, but these have generally sustained in reviews of the data leading up to the present day. So we see a clear impact, and we see that impact carrying on. And with that, I'll pass on to the next presenter for you to hear about the qualitative results.
Thank you so much, Alex. This is Marsha Ellison. I want to shout out to the other members of the technical assistance team, Marianne Preskolrica and Colleen McKay, who participated with me completely in the evaluation of the qualitative results. Next slide. So we did want to check, as Megan began, by listening to people on the units. We also wanted to listen to people on the units subsequent to the pilot and see what they had to say. So we had 39 staff interviews at all 3 pilot units. We used a structured in-person interview. The interviews included people at all levels: mental health workers, clinical staff, and leadership. We asked questions about the major pilot initiatives that you heard about from Julianne and their overall experience. Next slide. So overall, in general, people said that they actually experienced the reduction in aggression and restraint incidents that Alex referred to. They reported that they felt safe on the floor. They reported that they were able to use the approaches that they were trained in. They really appreciated them, and they began to focus on de-escalating threats instead of seeing patients as threats. And there was a shift from using restraints to having staff presence and a reduction of hands-on interventions. There were some reports that they didn't think there was much real change because they felt that there wasn't that much aggression in the units to begin with, and sometimes whether the improvements that they saw were mainly due to changes in the patient population rather than to changes in their behavior or policies on the unit. But that was a smaller voice compared to the larger voice of satisfaction with the pilot. Next slide. The many staff noted appreciation for the trainers. I'm just saying that out loud for Julianne's benefit. People really enjoyed the trainings. They did mention that some were not set to the educational level of trainees, and they would have liked more time to learn techniques. But in general, the training boosted staff ability to manage agitation and aggression. Next slide. There was quite an emphasis on the value of the dialectical behavioral therapy training that was delivered. They described it as great, helpful, a thing to believe in. They just wanted more and to make it more accessible to them for staff that were arriving in the middle of the night or via public transportation. Next slide. You heard a bit about the Brossette scores, and even though there was a dramatic reduction in high Brossette scores, the staff were not too fond of the Brossette scores. We heard that it was a waste of time, numbers don't matter, that it was redundant, and they struggled to understand the tool, figuring out what was a normal score versus an escalated score. So that's being taken into account by the Office of Inpatient Management to think about how better to utilize Brossette scores. Next slide. We did check in with the mental health workers about how they felt regarding involvement in treatment planning, a major effort in the pilot. And it was pretty much unanimous that when they were included, they really appreciated that opportunity. They felt like they learned a lot. They felt like they could share a lot, and that also clinical staff and leadership were listening to them. So that definitely improved their sense of preparedness. There was quite a bit of discussion about the reports at the end of shift and how that has been an improvement of communication between clinical staff and mental health workers. Some still felt a divide between clinical staff and the mental health workers that undermined morale. So we did hear that voice as well, but the majority of people spoke well about their new involvement in treatment planning. Next slide. Regarding the MAN training, they perceived it as helpful and good, but also some considered it overwhelming, hard to remember everything. And also that it did not address the physical management needs that some still encountered. There was a note about the staff could listen to the psychopharmacology consults. They could listen all day. Some really loved it, whereas others described it as being too remote from the daily issues that they were encountering. Next slide. I'm going to very briefly mention that we also at the same time developed a training module to manage escalated behavior in the community. Next slide. We did this in a very close consultation with community ACCS providers, and we also learned from their prior training modules what they already had and what they still needed because aggression incidents were happening in the community as well. Next slide. Our process was to develop a design team, and you could see the various agencies that participated very closely with us in designing what the training module should look like. Next slide. These are the 7 sections that are in the resulting module. You can see them here, and this module will be, it is being vetted by the Department of Mental Health presently and will be made available in the ensuing months. Next slide. Just a shout out to the iSPARC Technical Assistance Program. We are here to provide technical assistance to the DMH workforce, including provider agencies and contracted agencies. We have already a series of training modules for the ACCS agencies and community, and you can see the names here. We provide a variety of other things, including like literature reviews, best practices, and so please do look up iSPARC on UMass Chan Medical School site and submit a technical assistance form, and we'd be happy to help as we can. With that, we're going to pass it on to the members of the units led by Julianne and Kara, and this will further demonstrate to you the impact of the pilot on workers and staff.
Thank you for the introduction, Marsha. Good afternoon, everyone. As mentioned in the beginning of the conference, my name is Kara Souza, and I am the informatics nurse with Department of Mental Health, Office of Inpatient Management. It is with great pleasure that I'm introducing the pilot unit teams and to have them speak about their experience with the aggression management pilot. We'd like to start with Solomon Carter Fuller Mental Health Center, Kristen and Jean.
Thank you, Kara. Thank you, everyone, for joining us today. My name is Kristen Topher. I'm the nurse manager here on 8 East.
My name is Jean. I'm an MSW on 8 East.
All right. So last year we joined the pilot program in about March. It was a little bit of a pivot for us. So we jumped right in and we were ready to go. Give you guys a little bit of background of who we are here at the Fuller. We are a 60-bed inpatient adult forensic psychiatric facility comprised of 3 units. Our unit that we work on has 18 patients. Most of our patients have been sent to us from the legal system. They have a long history of aggressive behaviors, involvement with the legal system and correctional systems. A lot of our patients do have charges ranging from trespassing and disorderly conduct all the way up to murder and sexual offenses. So they do come with a background in aggressive assaultive behaviors. As we discussed earlier, this project started in a little bit of the post-pandemic phase. Listening sessions were conducted with staff from all disciplines. It wasn't just nursing and mental health workers. It was nursing, mental health workers, social work, OT, psychiatry, psychology, and our peer specialists. And then the information that was gained during these sessions was shared with administration. And that's how we jumped into this project. A lot of the concerns shared during this time were overall unit safety. People were worried, am I going to come into work and be assaulted? Will our patients hurt each other? Things like that. We also voiced concerns that the patients appeared to be more aggressive. Post-pandemic, we had a lot of folks that hadn't been treated for some time, and now they needed treatment, and we were the place to be, but they were more aggressive. Some staff reported feeling that our staffing ratios were not adequate in relation to the acuity and just feeling unsupported. So what happened, as we said, we were chosen as a pilot unit and we went back to basics. We talked about why do we do what we do? Why are we doing safety checks? Why are we monitoring the environment? Why are we giving people PRN medications? Talked a lot about who are the people we're treating? What's their background? You know, what illnesses have they had? What involvement with the legal system? What involvement with the mental health system? And then what are our goals? Like in the end, what do we hope for our folks? So as we discussed, our phase 1 was the foundation, and it was 3-hour training sessions conducted on the unit. So we actually had our sessions here on 8 East, and we scheduled it during our staff's working hours. So no one had to come in. The overnight folks didn't have to come in at 7 a.m. or stay late or anything like that. We did it during their shift, and it was really great because it fostered that sense of teamwork. People were willing to stay so others could attend the sessions. We worked together and we were in groups of the folks that we work with on a daily basis. And it really provided more of a teamwork and also that family feeling that we're all in this together. We want to help each other. We want to help our patients. And at the end of the day, just, have great communication amongst all of us. And also we found that by doing this, we were also comfortable. There wasn't really any silly questions. If I had a question, I wasn't going to feel embarrassed because I was with the people I work with every day. And maybe they had the same concerns as I do. We talked about real life experiences. We would bring up a topic and we would discuss, oh my gosh, remember when that happened with this person? What should we do? What can we do going forward? We talked a lot about the whys of what we do. Why do we do safety checks? Is it just so we get our steps in every day? No, it's to ensure that our patients are safe and, we're meeting their needs. We also talked about the importance of communication. And I think that was something that we were kind of lacking. Sharing, seeing something and saying something, making sure we were all on the same page to kind of notice any red flags or maybe some folks who needed help. We could address it in the moment and come up with real-time solutions. We also talked about the importance of our documentation in that everything should be documented, so everyone can see it, not just a little side conversation about an activity or an event that happened. No, let's document it in the medical records so the providers, the social work, the whole interdisciplinary team is aware of what's going on. And there's just a big focus on teamwork. And it wasn't just nurses and mental health workers. We talked about how important it is to have the social workers on the same page, and the occupational therapists. If, one of our counselors came to us and said, so-and-so isn't behaving like they were today, we're going to share that with the OT staff. So they know maybe that person shouldn't be in group just yet. The next steps we took were to take a deeper look. We reviewed major mental illnesses, their symptoms, the medications. This was really great because a lot of us have been here for a long time, and you kind of forget the intricacies of different illnesses, or why certain medications may make someone sleep later in the morning, or maybe someone feels a little irritable because they missed a PRN that they probably should have been offered. We talked about what do certain diagnoses look like. We also pull that into substance use. We talked about the various substances that are out there, and it was great because there's a lot of substances out there in the community. We don't even think of this, and a lot of our patients have dual diagnoses. So just wondering, what does withdrawal look like? So staff was really able to ask questions about that, and also be aware of, if someone's in their room, they're not eating, we're noticing them sweating, hey, let's get the doctor on board and let's talk about this and how are we going to help this person who looks like they're going through withdrawal. Because of this, we were able to then change our visitor guidelines. Now all of our visits are 30 minutes. They are supervised by a staff member. If we notice something, we say something. I've had staff come to me and say, hey, I'm not comfortable with what's going on in this visit. And it's been great because we've been able to stop an issue before it starts. We talked a lot about the SWAP, which is our safety wellness action plan, and just realizing that we're not looking at this just when someone's having an issue, but we're looking, what does it look like when you look good? What is a good day for you? And then documenting this and making sure it's available for everyone on the unit to know. We talked a lot about not just jumping to a restraint event. It's verbal de-escalation. We notice someone escalating, it's how can I help you? What's going on? Let's take a walk. Let's talk. Let's listen to music. Things that we kind of had gotten away from. And just being aware of changes in the environment. If we notice that a door isn't shutting the right way, hey, let's talk about this. And maybe someone was planning on doing something. We also, as we said, we brought in DBT, and we're just starting that, really rolling it out and working on the skills and making staff be aware what the skills are and how can we help our patients. And what we've learned is that people are just feeling more comfortable. I've noticed a lot more communication. I've noticed a lot more documentation. People referring to the SWAP, people being aware of things that they need to be reporting to us. And it's just been great because it's not just, as I said, the nurses and mental health workers. We're pulling everyone in. And so we're all on the same team. We're all on the same page and kind of seeing issues before they start. Jean, do you have anything to add?
Salamanca in Timor, some great opportunities for me to be part of Salamanca for a team and do my best for the safety of the patients and for everybody in the unit to keep the unit safe and to be part of DMH. Thank you.
Thank you, everyone.
Thank you so much, Kristen and Jean. Next, we'd like to move on to Worcester Recovery Center Hospital, and we have Isaac and Nilsa.
Hello, everyone. Isaac.
And I'm Nilsa.
And we were privileged to be part of the Aggression Management Pilot Project. Worcester Recovery Center is a 320-bed facility, 10 units. So our unit is one, and our sister unit is a part of the court evaluation units for the hospital. Most of our patients come from the correction settings and also the court systems, and mostly for evaluations. So oftentimes they come in, with not a lot of history. Some of them unmedicated, going to withdrawal. We all know the prevalence of dual diagnosis in the community, and a lot of them have been not adherent to their medications. And these are all risks for violence when you look at the background of the patients that we treat. And then coming to our unit is often also not being able to be medicated right away, because oftentimes they are symptomatic and they will refuse medications. And they will be aggressive, secondary to their mental illness, and it mostly was challenging. So it was real relief for us to be included in the aggression management. We used to talk about this as if Our unit was, the pilot project was just coined for our unit. Essentially, and our sister hospitals are coming along with us. But we don't mind sharing Dara and Julianne and the entire OIM crew that were very helpful to us during this process. And Kristen has said a lot, and I mostly, we had similar experiences during the course of the training. And what I would like to highlight is the impact of what the aggression management has left us. That whole training has really left us with a very formidable structured unit that really supports the patient population that we have. I would say that one thing that we realize is that the evidence-based tools for aggression works. It works, but it's as effective as the staff who are implementing it. If you don't have the staff buy-in, you will have the most expensive or the most, robust plan, but then the people that are with the patients 24/7 will not have the ability to implement it because there's no buy-in. What this aggression management pilot taught us is that the tool is effective, the staff buy-in, and the results will come in place. And so what we found out was that staff felt supported by this pilot project. The fact that we are discussing aggression at the workplace and that administration or DMH has the priority to set consultants aside, set people aside to come to the unit, meet with people who are working overnight, was the game changer for the staff. They felt like they've been heard, they felt empowered, and it was such a remarkable turnaround for us on our unit. Number two is the collaboration that happened because the floor staff were involved in the aggression management project. We literally revamped our whole schedule system and the structure of our unit to meet the goals of this project. And it has lasted up to today. That staff are actively involved in treatment teams. So it's not like they're not coming to the manager to tell you, this patient yelled at me yesterday, attempted to assault, and then they are off wing restriction. However, the staff are saying, he's been on wing restriction, he's managed good behavior control. Doctor, let's take the patient off. They are advocating for the patient. So collaboration, we saw significantly improve staff advocacy. Staff are running groups on the units. Staff are telling me, oh, this is a calm app. We can use it to run group. We have movie nights. And we go from staff coming to me that things are not in order to telling me that these are the things that we do for patients. Before I'm going to hand it to Nelson, I want to say one more thing. There was an incident that most of our restraints and altercation with our patient happened overnight. So we decided that we're going to incorporate during the aggression management pilot, incorporate the patient needs on overnight, which a lot of them get agitated when you flash a flashlight. So we said, okay, when they come in, we're going to tell them, this is what we do, but if you don't want it, this is the other plan. Where we open your door slightly, we turn the bathroom light on, so there will be no flashlight. So you won't flash, and this significantly help us on the unit. So we don't have a lot of time. I would have talked, but I would like to highlight the work that Elsa did, and I'm very proud of the work that she did during this project, and I would like her to say a few things.
So my name is Nelsa, and I work on B1 unit, and it's a forensic unit. Our unit staff care of patients often are unmedicated. They have struggles with the mental illness, behavioral issues, as well as substance abuse. This project really made a difference to me and us in the whole B1 unit. It helped us bring the whole team together, the MSWs, the nurses, the psychiatrists, and as well as the social workers. It made us collab and feel more natural and consistent. As an MSW, it meant a lot to me to finally have a voice during treatment teams and rounds. And it just, because we've been the ones that spend more time with the patients. And being able to share that in the real time helped us build understanding with the patient's behavior and respond more effectively on the floor. Also, the strength that they gave us as well with the pilot program was the de-escalation skills that they gave us. We learned how to better or recognize where the patient is in the crisis cycle and how to respond more calmly and structured on the floor, as well as the DBT skills approaches that we got introduced gave us the practical skills to communicate with the patients, help them regulate emotions, and reduce the conflict. Another impact that we had as well was advocacy, being able to discuss and allowing us to speak for both patients' needs and staff safety. It also felt like our input was truly mattered and helped us care, plan in a meaningful way. Also, it also became more aligned as a team by improving our understanding of the policies and using the tools like Brissette. This helped us stay on the same page and identify the patients who needed more support earlier before the aggression started. In this pilot program, it helped us just work better, improve our de-escalation skills in situations, and using the DBT skills and just gathering, making sure that the frontliners have a strong voice. It just made the unit feel more safer, supportive, and connected with both staff and patients to work together for a better unit. So thank you so much.
Thank you.
Thank you so much, Isaac and Nilsa. And we'll pass it off to our final facility, Taunton State Hospital, Tilly and Donna.
Hello, everyone. My name is Tilly Feliciano. I am the nurse manager here for Cane 3 West at Taunton State Hospital. And I also have my lead MHW, Donna Brewer, who's also my champion for the pilot. She'd like to start.
So my name is Donna Brewer. I am the champion for our pilot unit here at Cane 3 West at Taunton. We were excited about being chosen for the pilot unit because it gave us an opportunity to know more about our job. Also, it taught us how to work as a team. The communication was a big factor in everything that we did and learned. As mental health workers, we are now included in decisions with treatment teams, and we're now involved in shift reports. We have the use of the Brissette to be thankful for, which help us identify behaviors. We're grateful to have special training classes where we learned about aggression and behaviors, what to look for and how to interact with the clients. This program has brought so many great things, most of all the unity of the entire staff, now working as one, which brings us back to communication. Being able to meet and consult with Dr. R and Dr. F was very helpful with navigating patients' behaviors and strategies in dealing with issues that came up on the unit as well. Also, one of the major things that came out of this is the ongoing leadership meetings we have with the MHW 3s and 4s with our OIM meetings monthly, which led to us meeting with the COO once a month here at Taunton State Hospital. It's great to finally be heard and validated for the jobs that we do. I'm just grateful for having this opportunity to be a part of a great program, which I would love to see it extended to the other units. To have everyone being consistent would make a great working environment. Thank you. And now Tilly.
Thank you, Donna. I agree with Donna 100%. The OIM aggression management pilot overall has had a positive impact on Cane 3 West. It was truly a great experience for the entire unit. I feel that it made us so much stronger. It brought us closer as a team. There was a lot of consistency. There still is a lot of consistency. Everyone is on the same page, and communication has improved tremendously on this unit. staff training and the approach was highly praised by my staff. I received nothing but positive feedback. A lot of the times when I'm saying, oh, you have another training coming up, it's always like, oh, another training. But when I mentioned phase one, workplace violence, very interested. Oh, I want to know more about that, you know. So they were eager to attend, eager to participate in the pilot. We not only were taught workplace violence and all the information, but we also discussed many more. We talked about the RL6 incident reporting system. Everybody can do it. All the staff can do it. They felt valued. Okay, I can do this myself. I don't need somebody doing it for me. The SWAP, Safety Wellness Action Plan. Usually, as I was a charge nurse on the floor, it would be the nurses, the social workers. Now it's MHWs who are all participating as well, and they want to do it. They're taking initiative to do it. As needed, whenever we have to do it besides monthly, you know. High risk huddles, very important. I have a binder that is so thick on my unit because we use it so often with difficult clients and suggestions, so much that the staff will come to me. Okay, we need another high risk huddle. We have to do this because we now have this client. Like, let's get together, strategize, and see what we can put in there. Awesome. It works so well. Not only does it work well, I have my staff introducing it to other staff that float to our unit that don't know much about our clients. And they're like debriefing them on it and saying, here, this is the high risk huddle. This is all you need to know about this client so that we can maintain safety and that kind of thing. We discussed mock code grays, constant observation, 5-minute checks. There was so much that we went into. They also provided us with the MHW toolkit for the floor so that it has so much resources, including radar, the crisis cycle, high risk huddles, and so on, the SOTA model. We discussed phase two. We trained for phase two, and that was the substance abuse training, which was very well received because a lot of my MHWs didn't have a lot of experience in that area. So it was very important for them. Not only that, we discussed forensic admissions, thorough skin assessments for my nurses, the ProSet score, visit policy, contraband. There was so much discussion, so much learning happening in each of these sessions. So it was very, very positive. Not only that, we did have phase 2B, which is an additional teaching for substance use, which was, again, very helpful. We brought DBT back to Taunton, which was awesome because I was here before when it was here. This is something very important and it's been implemented. So I'm very happy with that. The MHW advisory committee. So now that they have a voice with the lead MHWs, with the COO and leadership combined, it's just so important. Also, treatment team had training, all of us together, collaboration on, you know, graphing risk trends with the ProSet. And an example was we had a difficult client, was very aggressive at times, and then the guardian was not believing any of that. So we were able to demonstrate the trends of how it, with the ProSet scores, and show the guardian, who was like very impressed and then felt really like, oh my gosh, apologetic, I'm sorry, I can see this a lot better and understand it now, and was very, very grateful after that. So we also, the shift report, and including all of the MHW, all staff in shift report, very important as well. That was like a key component with communication. Everybody is in the know. There's no information being missed. Same thing with the treatment team. Participating in the treatment team, they are direct line. They're right there. They know everything. So they bring it to us, and now we know exactly what's going on and how to handle that client. So that was very important. Case conferences as well that we had consults on made a big difference. I have so many examples. We were told certain recommendations, med changes, we did them. And some of our clients have unsupervised on grounds now. Some of them on discharge tracking lists. So basically all around, it was just a really good experience. And I highly recommend it for everyone, because for all the units, because it really did make a difference in the data. And I have a complicated client now, and it's working. It's working. I can already see it working. So I'm just happy with it, and I wanted you all to know about how well this program was for us. Thank you.
Thank you so much, Tilly and Donna. I'll now pass it over to Megan for our question and answer session.
Thanks, everyone. I really appreciate the presentation and the incredible panel discussion today. Thank you so much for representing your experience of the pilot. So we have a few questions in the Q&A, and we have some time to go through them. So the first question is, were any surveys, focus groups, or qualitative interviews done with patients on these wards? In particular, wouldn't patients have insights to share on why aggression happens and what would cause it to increase? Also, what about the impact on other patients from their point of view when there is an incident? So I can, I'm asking the questions, but I can also answer if that would be of help. So for that one, and please for anyone else to contribute, that's great too. So I guess my response to that question would be, we agree that patient perspectives are critically important for understanding reasons for aggressive behavior in inpatient settings. Patients are uniquely positioned to provide their insight into perceived triggers. So that is a really important source of information. In this process improvement initiative that we conducted, our primary data collection was focused on staff perspectives. So, and this decision was driven by, several things, several pragmatic and ethical considerations about how we would ask questions of the patients, as well as the need to rapidly inform, practices, unit workflow, safety practices. So, and we can see that focus has had a positive impact in the pilot units. But I think it would be a great component to include in future work. So that from my perspective. Does anyone else want to contribute to an answer on that? No.
I would just include one more detail from the quantitative analysis side, that the aggression and assault incidents we included patient-to-patient incidents. I know that's not exactly the question, but that we were looking at outcomes data also related to patient experience and, of course, strain and seclusion.
Thanks, Alex. So that's a great question, came up a couple of times, so appreciate that being asked. All right. So I know we want to get some questions in about the presentations and the panel. So for our presenters today, what were some issues or challenges that came up when implementing the training?
So for us, as we mentioned, my group came in a few months into it. I think it had been the pilot program had been going on for about 6 months, 5 or 6 months prior to us jumping in. So that was a challenge in itself because it wasn't a pilot we were involved in. So kind of catching everyone up to speed in like a 2-week span before we started the on-unit trainings, that was a little bit of a challenge. And then just scheduling people to come in. I actually thought that was going to be a challenge, but it worked out much better because once we explained it to everyone, we had a lot of buy-in, a lot of people excited for it. And I think it was just, the other challenge was because we were a pilot, a lot of my staff does float to other units. So they were kind of trying things like talking about the swap when they would float. And some of the other 2 units were like, wait, why are you guys focusing so much on this? So that was a little bit challenging. And then they'd come back like, guys, they're not doing that. I'm like, and we'd have to remind them, no, we're the pilot. And then, yeah, I think that was it. We really didn't, it was just the initial for us because we came in a little late to the game. That was the challenge. But once we got the ball rolling and people were excited and interested in learning and being able to use their skills, it was okay.
Thanks so much, Kristen. Anyone else want to contribute to that one?
I think from our end, we had some challenges when we started the project. I think there was this big staff issues that we brought up during the initial phases of the pilot project, and we had to gather enough information for our trainers and our facilities and school and coordinating this. And my interpretation as a nurse manager at that time was that we were doing enough here. What is all these coming from? And it's coming from staff that we thought they were happy and included and excited. So we could have easily become defensive and said, excuse me here, we are trying our best here. But what we did was that we embraced what the staff brought to bear. And then we started working as a team together with our facilitators. And I think that really helped. And most importantly, before I will end, I think our clinical team also felt empowered because when our consultants came, most of the recommendations that they put in place are recommendations that were already in place by our hospital and our clinicians. So I think overall, there were some challenges, but we felt that we had the men and women to produce at that point.
Thanks, Isaac.
So for my unit, I didn't run into too many challenges, but it was the training offered was very flexible, had a lot of different dates and times. So I was able to, post it for first choice, second choice, whatever. I wanted them to feel like they were being part of it and that it wasn't going to inconvenience them. So they were more motivated to sign everybody. Every time I would leave it, sign the post up and then come back and it was all filled out, So that made it a lot easier for me to just assign everybody at that point because it's actually what was convenient for them and it worked for them. And again, all 3 shifts being trained, it was very helpful. The 11 to 7 shift didn't have to come in on their time when they're already tired, being up all night. So it was very helpful for that. It was a little bit challenging when it came to the end when we did data collection. That was fine, but the interview process and everything, a little nervous about that, but I was encouraging them that it's a good thing. And then before you know it, they're just talking, everybody's there talking. So it was they just had to get past that part and then they had a lot to say. So that was pretty much it. I mean, it was relatively easy to motivate them and get them going because they were interested in something like this. Workplace violence is very big. You know what I mean? So it's very interesting to my staff.
I would just like to add that from our perspective as bringing the training in, the anticipated challenge was staffing. Absolutely. And it turned out to be a non-issue, and buy-in, initial buy-in, some skepticism or what's in it for me. And I think once we started and it was something that wasn't being done to or check off this box, it was about them. And we did that all in collaboration. You're hearing about the nurse managers being present for the training, that this is something really important. So I think that went away fairly quickly. And then just the other piece I would add would be, maybe more on and not across the board, but maybe clinically speaking, some clinicians will, that's milieu stuff. So ensuring that everybody understanding what integration means and that how everybody contributes and working together and just providing it. So having mental health workers in treatment team, very valuable understanding, oh, wow, this person brings a wealth of information and the opportunity for the mental health worker to also gather some more insight onto the illness and what that might look like and the behaviors on the unit so they can reframe instead of, someone said it earlier, instead of getting upset or angry or reactive, saying, oh, wow, this might be what's going on with this person. I know what to do. And so really getting proactive. So I think the challenges we anticipated just didn't exist once we kind of started. So it was kind of a very nice experience.
That's great. All right. So for the reduction in scores and restraints, what do you attribute the reduction of aggressive incidents to? Was there anything specific that was most helpful?
I think from our end, it was communication. I think that really people kind of had it on their radar. So-and-so had a challenging night last night or got some bad news. So we were able to kind of look for behaviors that sometimes in the past, for some of our longer term patients, that led to a restraint. And just staff kind of coming up with a plan like that, communicating okay, well, as the nurse, we're going to offer a PRN. And I may have a mental health worker who says, you know what, I know this person enjoys listening to music in the sensory room. So we're going to do that. And just having these discussions in the shift reports, kind of pulling people aside to huddles off to the side and formulating a plan before we saw the person really start to escalate and, get into the full crisis cycle, we would kind of meet them where they're at, identify things that we can do to help. And I think it just staff becoming more confident in their skills and knowing I'm here for a reason. I'm not just here to do safety checks and, log all of your belongings when your visitor comes, but like feeling confident in that, like, I feel confident looking at your swap, and you say that you enjoy, time listening to music, or you enjoy having art supplies handy. I think that really helped because the staff, as I said, the staff felt more confident. They felt like they were being listened to. And I think the patients also were seeing that, like, I don't have to engage in maybe an unsafe or aggressive behavior to get my needs met, but people are actually listening to me when I say, I like spending 20 minutes with an ice pack on the back of my neck because that helps. They don't have to go and punch a wall to get the ice pack. It's those types of things.
We also saw increase in engagement on the part of our staff. And I think that made the patients feel safe. A lot of these aggressive tendencies sometimes stem from the fact that patients feel unsafe. And for patients to feel safe in an area, especially ones that are acute, they need support from staff at baseline. Reassurances that they are safe, that their needs are going to be met, and that if they have any challenges, they can talk to staff. And I think that increase in engagement really made the patient feel safer in an environment that can be very difficult.
I believe that communication is very key. Like, it's key for sure, because they learn so much in the treatment plan. They know the goals. They know what they have to do to help them achieve their goals. They know they will come to us and tell us certain things that might be missed in shift report. And then we're like, oh my gosh, we didn't know that. Thank you so much. If they, it's very helpful, and everybody's like pretty much in the know, you know what I mean? That works. It just works. And I think it's helping us to be able to nip it in the bud, de-escalate, talk. They know their swamp. They know what works for them, what doesn't work. They know what their goals are. So they're just in the know for sure, 100%.
Thanks. Okay, I'm going to try to sneak one more in before we go to break. So, to what extent do you think it's the content and the expertise of the consultants that led to apparent reductions in violence, as opposed to just paying attention to direct care staff and offering them a place to pause and reflect on the work? So there's a little bit more to that question, but I wanted to just pose that.
I think from the feedback that I received from the folks that were involved in this project, having the consultants come in and give us positive feedback on the interventions that we're doing. One of the patients we presented, very reluctant to participate, to even speak with his provider, like to even speak with his psychiatrist, has been involved with the mental health system for a long time. And we were kind of feeling frustrated because we were, encouraging him to come to groups, encouraging him to come to treatment team, and he wouldn't. And with one of the consultant sessions, it was really nice to hear that feedback. Like, okay, well, yes, you are, offering him these things. Everything you're doing, you're meeting him where he's at and listening to what he's saying, even if it's not being said out loud. And I think that was really great feedback for the interdisciplinary team, because we were feeling frustrated because we weren't seeing any progress despite everyone's efforts. So I think having the consultants come in just gave us some validation as to what we're doing, and made us feel like, yes, we were doing what we were supposed to do. And there weren't really many other suggestions that they could come up with this particular case, because we were, I don't want to say check the boxes, but we were doing everything we were supposed to do, like providing the right medications, involving occupational therapy, trying to do all these modalities. And we were meeting him where he was at. So it was nice to hear that was okay too. That we weren't seeing this like great recovery that we were all like hoping for, which in the end it did happen. We had to meet him where he was at. And at that point he wasn't ready. So it was nice to hear that we were on the right path.
That sounds great. I want to thank you all again for this fantastic presentation and panel discussion. There are some questions in the Q&A that are left over, and for the one that we just asked, if anyone else wants to contribute to that one, please feel free to type in an answer, and we will continue to answer those questions as we go along. So it is 1:59, seconds away from 2:00. So we'll take a break here for about 10 minutes and come back at 2:10 and resume. So thank you very much, everyone.
Okay, welcome back, everyone. That was such a wonderful presentation. And I'm so grateful to all of the people who took time out of their day to make that presentation and really tell us what was happening at the hospitals with the pilot. It is now my incredible pleasure to introduce Dr. Cheryl Fu, who is a beloved colleague and Associate Director of the Center of Excellence for Psychosocial and Systemic Research here at Mass General. She's also a clinician who is a Director of Family Services for our first episode and early psychosis program, and a researcher, and is Assistant Professor of Psychology at Harvard Medical School.
Thank you so much for the introduction, Khoury, and thank you all for having me today. I want to start actually with a little origin story of how this whole initiative began. So a couple of years ago, I was pitching a project to develop an intervention that would improve the patient acceptance of long-acting antipsychotic medications during the hospitalization period so that it kind of stops this revolving door of rehospitalizations and relapses. And I shopped it around in both inpatient and outpatient settings, and the overwhelming feedback that I got from providers then was, I really want to support you. I also want to get more clients on long-acting antipsychotics because I know that they're effective and we've seen them work for people, but I don't know where to send them or where my patients can go to get them conveniently after they get discharged. And that feedback told me that the access problem on the outpatient basis had to be solved first, and no patient or provider facing intervention can scale until that access problem is solved. And that is how this statewide partnership and coalition was formed to ensure that there is no wrong door to accessing life-saving, evidence-based medication treatments for people with serious mental illness living in Massachusetts. Starting with the long-acting psychiatric medications. And today I will cover the problem that we're trying to solve, introduce our coalition and implementation science approach, share some preliminary findings as well from the first part of our landscape analysis with the community behavioral health centers, the CBHCs, hear directly from people with lived experience as well as a provider, and end with where we're heading next. Next slide. Before I begin, I also want to acknowledge that this is truly a coalition team effort, and everything that I am sharing today has been shaped by the strategic direction and thought leadership of all the agencies, behavioral health organization leaders, and champions that are named on this slide. For the sake of time, I won't be able to name every one of them, but they have all individually just added so much value to this work since 1 year, 2 years ago. And finally, the heart of this work right now is with the community behavioral health centers, the CBHCs. So I know many of them are in this room today. So I want to thank every CBHC team, their CMOs, medical and operational directors, the providers, as well as their executive leadership for sharing the same vision and being so engaged in and committed to this work. Next slide. So let me start with the problem we're trying to solve. People with serious mental illness and substance use disorders experience repeated hospitalizations. And in our initiative right now, we are focusing on people with schizophrenia spectrum disorders and bipolar disorders, opioid use disorder, and alcohol use disorder. And for these conditions, medication is the first-line treatment, but accessing them and then adhering to these medications on an ongoing basis is incredibly difficult. It's difficult for anyone to take a daily pill, right? But for people with these conditions, missing a dose can risk relapse and longer-term disability. In fact, 1 in 3 schizophrenia-related hospitalizations are driven by poor medication adherence, and this costs over $100 million a year nationwide in preventable inpatient costs. The pattern is similar for substance use disorders, for opioid use disorder, where poor adherence drives recurrent use and overdose risk. The good news is that relapses are preventable because poor adherence is also preventable, and we have a proven tool for it, which is long-acting psychiatric medications. And the medications shown in green on this slide, antipsychotics, naltrexone, and buprenorphine, are ones with long-acting formulations that our initiative is focusing on currently. Next slide. So what are long-acting medications? They are administered by injection, typically monthly, slowly releasing the optimal daily dose of medication in the body over time, and this reduces the burden of taking pills daily and therefore facilitating medication adherence. And the pharmacology is also doing some work with preventing breakthrough symptoms. So as you can see from the figure on the right, long-acting formulations ensures a consistent, steady medication level in the bloodstream versus, rapid fluctuations with daily pills. And there is robust evidence to show that the long-acting version works way better than the pill form. So across meta-analyses of randomized control trials, real-world national registry studies, long-acting medications, antipsychotics, reduce the risk of medication discontinuation, hospitalizations, relapse, work disability, and even mortality by a substantial amount. And on the substance use side, there is less extensive evidence, but also parallels in improving treatment adherence and lowering healthcare utilization as well compared to the oral forms. Next slide. But despite the evidence, as well as the more recent clinical recommendations for early proactive use of these long-acting medications, these medications are actually vastly underutilized. So the National Council for Mental Well-Being last year called for at least 30% of patients with schizophrenia and bipolar disorder to be on a long-acting antipsychotic, and 10% of those with opioid or alcohol use disorder to be on long-acting naltrexone, and 10% of people with opioid use disorder to be on long-acting buprenorphine. However, as you can see from the orange bars, nationally in the US, we fall short, right? The US average sits at just 13% for the long-acting antipsychotics and just 4% for long-acting naltrexone, even lower for buprenorphine. And how does that look like in Massachusetts? Next slide. Massachusetts is actually on the lower end across all the states for long-acting antipsychotic use. So this is 2018 Medicaid data of about 25,000 middle-aged Medicaid beneficiaries with a schizophrenia spectrum disorder diagnosis. And our statewide average for long-acting antipsychotic use was just 7%. As you can see from the map here, there are county-level differences with the higher use shown by the darker green shade concentrated in the Metro Boston area. Next slide. There is also a similar picture of underutilization for opioid use disorder. So in 2024, only about 17% of the Massachusetts residents with opioid use disorder received buprenorphine or methadone, about 9% buprenorphine, 8% methadone, which is far below the national average as well as the recommended 50% benchmark. Next slide. And looking at facility level access in 2019, only 45% of Massachusetts substance use treatment facilities offer long-acting naltrexone, and only 13% offer long-acting buprenorphine. So there are clear access gaps as well, even in facilities that are specialized for substance use treatment. Next slide. So why the underutilization? The barriers are multi-level, and I will mention each one of them briefly. At the patient level, there are knowledge gaps, stigma, side effect concerns, as well as illness and social drivers that compromise adherence. And on the provider level, based on past clinical guidance as well as common practice, long-acting medications have often been, in practice, reserved for people who have a history of relapse or showing evidence of non-adherence. This has changed with recent updated clinical guidelines. Providers also anticipate that patients maybe will refuse, or this might be a potentially coercive or challenging conversation that might damage rapport, and thus that conversation just does not happen early on enough. But importantly, in randomized control trials, nearly 90% actually accept when properly informed, which tells us that, the patient and provider level barriers may be easily addressable, but it's the system level barriers that are really the rate limiting factor. The most willing patient and provider are not going to find long-acting medications a long-term treatment option if there are no convenient sites in the community that are able to provide it continually. And there are also issues with cost and insurance coverage and who can bill for administering the injection, as well as fragmented care coordination, especially from hospital to outpatient care transitions. What might be started in the hospital may not be able to be continued in the outpatient basis, and vice versa. So what these multi-level barriers call for are innovative multi-level solutions. And our job with this initiative is to understand how these barriers uniquely show up in the Massachusetts care continuum and what might be some Massachusetts specific levers and action that we can take and do something to address them. Next slide. And this is where our implementation science approach comes in. It is guided by a learning health system knowledge to action framework, as well as evidence-based implementation strategies. And we've organized our efforts into three overlapping phases. Phase one, which we focused on throughout the past year and still continue to nurture right now, is all about partnership and coalition building. Phase two, where we're at, is preparing for implementation by developing altogether a Massachusetts strategic plan for expanding access to and increasing the use of long-acting psychiatric medications. Which brings us to phase three, where we will tailor, implement, evaluate, and hopefully scale some of the solutions that we test out. Next slide. So the coalition that we've built over the past year is really the central engine of our initiative. Nothing gets done without them. And there is a saying that you've probably heard, if you want to go fast, go alone. And if you want to go far, go together. We, from the very beginning, were very intentional in making sure that we want to go far together to make sure that we have impactful, system-wide, and sustained improvements. So we've built a cross-agency coalition that includes leadership, representatives from the different state agencies that oversee various aspects of behavioral health care, from licensing, regulations, service provision, as well as the CBHC's networks, and as well as multidisciplinary clinical and research experts that span psychiatry, pharmacy, nursing, academic medicine, and also including advocates as well. And through many presentations and discussions over the year, we've shaped and aligned on the same mission critical goal. Next slide. This is just a snapshot of all the agencies and organizations who we have formal commitment for on this initiative, with incredible leadership at their helm supporting this initiative, which includes the Department of Mental Health, Mass Health Office of Accountable Care and Behavioral Health, Massachusetts Behavioral Partnership and the network of CBHCs, as well as Behavioral Health Helpline, Department of Public Health, and their Bureau of Substance Addiction Services, Bureau of Health Professions Licensure, Bureau of Healthcare Safety and Quality, Division of Insurance. This morning, we just talked to Mass Health Pharmacy as well, Massachusetts Pharmacists Association and Association for Behavioral Health Care, as well as the wonderful MGH team, including MGH pharmacists, as well as the injection clinic. Next slide. So here's the vision that our coalition has aligned around, that people, we know that people with serious mental illnesses move across many settings, as you can see in the outer ring, the outer circle. And no wrong door means that whichever setting that someone is in, they can access long-acting antipsychotics, as well as long-acting medications for addiction treatment, these current treatments that we know work but are underutilized. Our priority setting for the near term is expanding access in the community behavioral health centers in Massachusetts. Since the CBHCs are designed to be the most local and conveniently located front door for behavioral health care, kind of the one-stop shops for a wide range of mental health and substance use services, as well as community crisis services, regardless of insurance status. And since they launched in January 2023, the CBHCs have served more than 100,000 unique patients in our state. A substantial proportion of them are living with serious mental illness. So that makes the CBHC network exactly the right place to start to ensure access to the long-acting psychiatric medications at the most local point of behavioral health care. Next slide. Our milestone objective this year is, as a coalition, is to develop a strategic plan for expanding the access and use of these long-acting medications. And to do so, we are starting with a comprehensive landscape analysis that includes understanding each CBHC's current practices, challenges, workflows through clinic-level surveys, as well as listening tours. We'll also be measuring the baseline medication use rates in each CBHC using guided electronic health record queries, as well as claims data. And this is important not only to establish baseline rates, but also develop a way for ongoing quality improvement tracking to know that whatever that we implement later on works and makes a difference. We will also have patient and family interviews to understand what their treatment experiences and preferences are. And in parallel, we are conducting ongoing evidence review. We are also dialoguing with the state agency representatives around regulations and policies. And this multi-method landscape analysis will inform our statewide summit that's happening this fall, where their coalition, together with the CBHCs, will prioritize goals and select strategies for an executable, next 3 to 5 year plan. Today, I want to share findings from this one piece of that landscape analysis, our CBHC clinic level surveys. Next slide. So the CBHC leadership, CMOs, medical directors, operation leaders, all completed this survey very recently in March and April this year. And these findings represent a first comprehensive look at the long-acting psychiatric medication capabilities across our CBHC system. Next slide. So this is how our CBHCs are spread across Massachusetts. Every dot on the map, one of them. All 29 CBHCs participated. That is 100% response rate. The two red outline circles are clinics that are currently undergoing organizational restructuring and did not participate. And what was really heartening to know from these surveys was that every single CVHC leader who responded reported being highly committed to achieving the initiative's goal in the next year. And I think that's a really important starting point to get that level of commitment. And then now it's about knowing what the practice gaps are and what the CVHCs need to provide the care that they want to provide for their patients. Next slide. So we asked whether providers prescribe each long-acting medication routinely, infrequently, or not at all, to get at whether underutilization was because of prescribing barriers. And across our CVHCs, 90% prescribe long-acting antipsychotics, and most of these, 24 out of the 29, are prescribing them routinely. Long-acting naltrexone is close behind at 86%, although more sites are prescribing it infrequently rather than routinely. But with long-acting buprenorphine, only 9 out of the 29, about 1/3 of these clinics are prescribing it routinely, and 1/3 do not prescribe long-acting buprenorphine at all. And when we asked the CVHCs why, the top reason for infrequent or no prescribing currently across all these 3 medications was the same: the lack of on-site administration capability and workflows. In other words, it's the ability to prescribe that follows the ability to administer. So if we want to move prescribing rates, we have to fix the ease of accessing continuous administration first. Next slide. So how does it look like on the administration capability? There are 4 different types. The easiest and safest way of accessing long-acting medications is when a clinic can both administer and store the medications on site, right? And that's about 1/3 of the sites for long-acting antipsychotics, a little less for both long-acting naltrexone and long-acting buprenorphine. About another 1/3 of sites are able to administer medications on site, but without storage. So that means that typically the medications are patient-owned. They get brown bagged, they get brought in. The patients pick it up from CVS or their local pharmacy. They bring it into the clinic, or it gets delivered to the clinic and then administered by the nurses. The number of sites that are represented by these 2 green bars are therefore those that can administer on site. And no surprise, because of the additional regulation hoops for buprenorphine, because it's a controlled substance, it requires additional licensing and regulations and REMS registration. Fewer sites are able to administer it on site. Shown in orange are where sites refer externally for administration. So they are referring their patients to other outpatient clinics, opioid treatment programs, OBAT programs, or even federally qualified health centers to receive these long-acting medications. More than 1/3 of these sites are referring patients elsewhere, especially for long-acting buprenorphine. And then 3 sites have no established referral pathways or on-site administration at the time of this survey. Next slide. So to make sense of this variation across our 29 CVHCs, we categorize the clinics into 5 different implementation profiles based on, each clinic's current ability to prescribe, administer, and store for all of these 3 medication classes. And each profile points to a different kind of support needed. So kind of signals that this is not going to be, or, we cannot use either a one-size-fits-all approach. So at the top, 6 clinics are fully ready. They are able to prescribe, administer, and store all 3 medications. And our support that we want to provide for them is to help them sustain this practice. 8 of the clinics are capable. They're administering these medications on site, but may have some prescribing or storage gaps for specific long-acting medications. 5 are currently scaling their capability. They have on-site administration for long-acting antipsychotics, but need more support, need more targeted support to do the same for long-acting medications for addiction treatment. 6 are developing that capability. They are prescribing, but relying entirely on external administration pathways, with a need to perhaps build capacity for on-site workflows or even more streamlined referral pathways. And finally, 4 are currently initiating that capability. They're only beginning to establish how long-acting medications can be part of their treatment services, needing foundational licenses and workflows to be established. So again, the green groups together are already able to provide on-site administration, and that's about 50% of the clinics. And our aspiration is for every CBHC to reach that level and help each clinic move towards more and easier on-site administration. Next slide. This is how it looks like across the 5 regions. As you can see, regional variation from Western Mass, Central and Metro West, Metro Boston, Northeast, and then Southeast regions. I'll highlight 2 things. One is that the Southeast region currently concentrates the most access gaps. Only 2 of 8 sites, as shown by the green colored bars, have on-site administration capabilities. So that signals maybe a region for more focused attention as we plan what supports we're going to use. And what's also encouraging is that actually every region has more than one site that provides on-site administration for all the long-acting medications. So this means that within each region, there are clinics that can share effective strategies and resources with the other clinics in the region, and they can perhaps also serve as referral sites in the near term while their neighbors build capability. Next slide. What's emerging as a promising facilitator is pharmacy partnerships. So 62% of our CBHCs report some type of pharmacy partnership, and 41% of them have a co-located pharmacy. So what do pharmacies do? They can play roles, as reported by the CBHCs, that span, as shown in the orange, navigating prior authorizations, helping navigate insurance and benefits, applying for patient assistance programs. They also, support the medication administration piece, storage, delivery. They also support patient care coordination and even provide provider education and consultation. So this is a really broad-based role that they're playing. And next slide. Also consistent with what we're finding in our systematic review, which is currently under preparation. We synthesized 27 studies of interventions that were designed to promote long-acting antipsychotic initiation and continuation, and pharmacist-led programs were actually the most common type, with 8 studies. And as you can kind of see at a glance with the heat map on the right, with the red outlined boxes, pharmacist-led programs are the only intervention type that addressed barriers across all the 3 patient, provider, and system levels, and also use the broadest range of evidence-based implementation strategies. So both our local practice data as well as what's published in the literature are pointing in the same direction. Pharmacy collaboration can be high leverage. I'll skip the next slide in the interest of time, but on the challenge side, hospital care transitions stood out, which is we know a high risk window for relapse and rehospitalizations. So 41% of the CBHCs reported significant challenges in inpatient to outpatient transitions, and more than 60% reported challenges for the long-acting naltrexone and buprenorphine. The main reasons were patient-related difficulty continuing and following through with their injection appointments, post-discharge, but also prior authorization and insurance challenges that interrupt treatment continuity. So they might be able to start the long-acting on the inpatient basis, but because their insurance change or perhaps their insurance were not verified, they lose that coverage once they go outpatient and then disengage from care. So this is really important and will be prioritizing inpatient settings and hospital care transitions in the next year. Focusing now first on making sure that we have more outpatient access points, because once we have that, then the inpatient teams will be much better positioned to start patients on long-acting medications, knowing that they can receive it post-discharge. Next slide. We also asked the CBHCs for their wish list items to expand the access and use of long-acting antipsychotics, and there were 9 that came up top. The top 5 are system and organizational needs to reduce prior authorization burden, improve care coordination for hospital transitions, and improving billing pathways as well. The next set are around implementation supports, including more learning collaborative and technical assistance and quality improvement supports. And we're already starting to do that with this initiative, recently starting a CBHC leadership quarterly meeting that's become both a place to share in a timely way the updates that we're gathering from this initiative, as well as, create a forum for cross-learning and resource sharing with the CBHCs. And finally, CBHCs are also requesting provider and patient-facing education tools. I think what's striking is that these top needs span every level. So again, we need a portfolio of strategies. Our listening tours that are going to happen over the spring and summer, we have our first one scheduled this Friday, are going to help us understand more of these specific needs, as well as learn about effective workflows and strategies that we can share with other CBHCs and think about scaling. Next slide. I also want us to hear from the people that this work is for. So in the next 8 minutes, you'll hear from 2 people with lived experience and their family members, and also from a provider and dear colleague, Dr. Katie Coole, who is a psychiatrist researcher at Boston Healthcare for the Homeless and Mass General Hospital. She's on the street team. She does outreach with patients who live unsheltered, and her research also focuses on homelessness and mental illness. So although our work is focused on the CBHC settings, Dr. Coole also shows how this effort can benefit one of the most vulnerable populations living with serious mental illness. I am so grateful to them for their willingness to be recorded and for their experiences to be shared. Thank you again to the patients as well as Dr. Coole for sharing these insights. There were so many important insights here, and I'll just highlight that access is important for patients, families, and providers. Next slide. This is a snapshot of all the things that we are currently developing, strategies that we are piloting and developing in the moment that will build towards the strategic plan, and each will be refined with service user feedback and tailored for what each clinic needs as well. And last slide, please. I'll just sum up with 4 key takeaways. First, that Massachusetts now has the first statewide picture of how long-acting medication access looks like in a key community care setting, as well as some beginning understanding of what we need to address. And that picture is going to get sharper with the CBHC listening tours, and we're going to extend the same approach to the inpatient settings next. Next, multi-level barriers cannot be solved with a single intervention, but really require coordinated action through a cross-agency coalition effort. Third, the strategies as well as the strategic plan is being developed together with everyone who is involved and impacted. So state agencies, CVHCs, providers, patients, to ensure that it's exactly what they want and it's actually feasible. Fourth, I see what we're doing, our SMI REACH approach, as a roadmap for bridging practice gaps in pharmacological treatments for serious mental illness, one that centers community academic partnerships and stakeholder engagement, rigorous implementation science, and also data-driven quality improvement. Next slide. Thank you. And I am so grateful to many of you who are part of this work. Many of you are in the audience today, and I look forward to continuing it together. Happy to take questions now and via email as well. I know we are out of time, so I will answer all the email questions in the chat.
Wonderful, Cheryl. Yes, it's an ambitious vision and an ambitious talk, a lovely presentation. I'll turn it over now to Megan, who is going to introduce our next group of speakers. Thank you.
Thanks, Khoury, and thanks, Cheryl, for an excellent presentation. So it's a pleasure to introduce our next set of speakers. So first we have Mr. Vincent Lorenti, who is the Executive Director of the Office of Community Corrections within the Massachusetts Probation Service. Dr. Dara Drawbridge is the co-director of the Massachusetts Center of Excellence for Specialty Courts, assistant professor of psychiatry and behavioral sciences at UMass Chan Medical School, and an executive leader of the National Collaborative for Implementation Support at iSPARC. And Dr. Michelle Crist is an instructor in the Department of Psychiatry and Behavioral Sciences at UMass Chan and an executive leader of the National Collaborative for Implementation Support at iSPARC. So their talk is entitled Strengthening Statewide Implementation of an Alternative to Incarceration Program. So, all right, you guys can take it away.
Thank you, Megan. Again, my name is Vin Lorenti. I am the Executive Director of the Office of Community Corrections. I'm really thankful to be with all of you today. I want to thank Drs. Drawbridge and Crist for inviting me to be part of their presentation. I also want to thank DMH and Mass General and all the organizations that have put this forum together today. I'm really thankful to be a part of it and to talk a little bit about what I've done with my colleagues in the probation department to try to bring alternatives to incarceration into our justice system and make them part of the mainstream of what we're doing in the justice system. Next slide, please. So first, I'm going to just say some background information, a little bit about our organization, about our values. Then I'll say a few things about why we do what we do. And then Drs. Drawbridge and Crist will talk a little bit about our partnership with UMass Chan Medical School to ensure that the programming that we're delivering in the community is being executed with fidelity to its design. First of all, the Massachusetts Office of Community Corrections, as you've heard, it's part of the probation department. In Massachusetts, if you're not aware, the probation department is part of the court system. So I work within the court system as part of the executive leadership team in the probation department. Our commissioner is Commissioner Pamerson Eiffel. I'm part of their executive leadership team there. The purpose of our organization really is to try to provide broadly is to try to provide safer and stronger communities by protecting community safety. We want to increase the ability of the justice system to protect the community by using community-based interventions rather than incarceration. Next slide. In terms of our values and guiding principles, there are about 6 that I want to go through quickly. These are, as you'll hear as I go forward, our organization contracts with community-based providers to deliver interventions through what we have called a network of community justice support centers. And so the values that you'll see on the screen are embedded in the contracts that we have with those community-based providers. But firstly, we want to make sure we do evidence-based practices. Obviously, everybody on this call is familiar with what that means. It means doing what the science shows works and doing it with fidelity to the design. We want to make sure that our programs are culturally competent. Beyond that, we want to be culturally responsive and culturally proficient, meaning that we want to provide spaces for transformation of our clients that are welcoming to all people that are in the justice system. Thirdly, we want to be trauma-informed. meaning that we want to recognize that our clients are coming to us typically with a lot of trauma, and that we want to be prepared to receive them as they are, and make sure that we are engaging in interventions that don't re-traumatize them. And typically this means making sure that our clients understand what to expect when they're working with us at the community justice support centers. Next slide. So we understand as part of the justice system that external motivators are present. However, we don't focus mainly on punishment or on coercion. We want to focus on personal motivation, and we want to work on intrinsic motivation. Therefore, we want to acknowledge that our clients' autonomy, that their decisions are their own to make, and that we can motivate them to make, hopefully give them the tools to make good decisions. We want to focus on skill mastery, as you'll hear, behavioral interventions in order to do that. And finally, and most importantly, we want to help our clients find a sense of purpose, purposes that are that transcend wherever they've been before in the criminal legal system, so that they can find a new path to safety and security in their communities. And finally, we want to build trust. That's very much why, or partly why we work with UMass Chan Medical School, to make sure that we're engaging with it, are consistent with science. And as you'll hear later, we want to hear from the voices of the people that we're impacting. And that's another way that UMass Chan Medical School has helped us facilitate a community advisory board as well. Next slide. So while I'm sure many of us are highly aware of the challenge of incarceration in the United States, I just want to take a few minutes to talk about this, to provide some context to why this is so important to our probation department in Massachusetts. So on this slide, you can see to the left, this data comes from the Prison Policy Initiative and from Boston Indicators. But on the left, you see a table which shows NATO members and the United States as the #1 rate of incarceration in the world and amongst our NATO partners at 614 per 100,000. Thankfully, Massachusetts has the lowest incarceration rate in the United States. Depending on which source you're looking at, it's either 241 or 172 per 100,000. Yet, as you can see from the slide, we are incarcerating a rate that far exceeds all of our NATO partners. Obviously, the comparison to NATO is, I think, made to demonstrate that there are other countries around common values and common systems with, and yet we are incarcerating people at a rate that far exceeds any of these natural allies. And while we have low incarceration rates in Massachusetts, we are still incarcerating at a rate that would make us the leading incarceration country if you compare us to the rest of our NATO partners. I just wanted to, just by a brief comparison, if you compare incarceration rates in Massachusetts with that of Quebec, Canada, the state of Massachusetts has roughly 7.2 million people. In Quebec, there's 8.5 million people. We are incarcerating at a rate of 172 per 100,000. Their rate in 2024 was 68 per 100,000. Just by way of comparison of one of the most important, I guess, crime statistics, the number of homicides in Massachusetts, there were 132 in 2024. In Quebec, Canada, there were 97. So the point here is to be made here is just to say that we are incarcerating at a high rate relative to the rest of the world. And yet, by many different metrics, I think you can make the argument that we are not receiving in exchange for that high rate of incarceration, the level of safety and security that maybe we would expect. The other thing I wanted to point out just briefly before we move to the next slide is that Boston Indicators, which I've highlighted here on this slide, did a report in 2024 to kind of talk about the criminal justice reform that had happened in 2018 and kind of track where we are. They noted that incarceration rates in Massachusetts have fallen faster than anywhere else in the country by 45% over the last decade. However, the disparate impact of that incarceration rate continues to fall on communities of color. They noted that between 2017 and 2021, while the white population saw a decrease of 40%, Latinos saw a decrease of only 32%, and the black population saw a decrease of only 21%. So I just lay this out just to say that it is vitally important for our justice system, for our probation department, for our entire justice system to continue to think carefully about incarceration and to find useful alternatives that are based and rooted in science so that we can get better outcomes for people in our community and make our communities safer and stronger. Next slide. So what we do in the Office of Community Corrections by way of following the evidence-based practice, and Dr. Drawbridge will talk about this at length coming up, but some of the core elements of this are rooted in what's known as risk-need responsivity. So number one, we assess the risk of our clients using an actuarial assessment tool. The tool that we use in Massachusetts is called the Ohio Risk Assessment System. It was created by the Department of Correction at the University of Cincinnati for the state of Ohio, and we've used that in Massachusetts for about the last decade. Designed to find out who are the people that have the highest likelihood of being engaged in the criminal legal system going forward. That way we can figure out what needs we can address with that group in order to mitigate that risk. And then also what are the barriers that exist to them getting those services so that we can help make them safer in the community. Secondly, we want to target the interventions. So what this means basically is just that when we find a need for a person, we want to make sure that they get a program that's designed to address that need. This may seem like common sense, but as you probably are aware, there are a lot of ways that our justice system focuses services strictly on people based on the charge that they present rather than the needs that they present. So we're working to make sure that we individually tailor interventions around clients' needs rather than based on strictly on charges. And finally, we are using a cognitive behavioral approach because we know based on research that a group cognitive behavioral, manualized cognitive behavioral interventions in a group setting are the most effective with the people that we're working with. Next slide. So this is generally speaking the risk need responsivity model that we're using. I talked about this a little bit before. I know Dr. Drawbridge will talk about this at length as we go forward, but it basically just means prioritizing the services that we have with the people that are at the highest risk for recidivism going forward, making sure that the interventions that we apply to those people or that we work on with those people are matched to the needs that they have. So we don't strictly look at a charge and then decide to provide programming to people. We find out what their individual needs are, whether it's education, employment, antisocial cognitions, peer associations, et cetera. And then we match those needs with programs that are designed to address those needs. And then how we do this is by making sure under the responsivity principle that we are knocking down any barriers that would interrupt a person's ability to get those services. Responsivity could be anything from trying to address transportation needs to actually trying to make sure that if people are suffering from major mental illness or serious mental illness, that we were addressing those things first before we try to get them involved in programming at a community justice support center that's intended to address their criminogenic risk. Next slide. So the support, this is just a list of kind of some of the things that the support centers provide. As I mentioned, we're doing manualized cognitive behavioral groups. There are a myriad of different programs out there that you can find amongst various different publishers that are designed to deliver services in these areas. We're doing education and employment supports. We are addressing essential needs of clients. Typically, we are doing this under the responsivity principle, meaning that any need that a person, as I mentioned before, whether it's transportation, maybe it's acute drug and alcohol use that we want to address, whatever those needs are, we are trying to address those through healthcare providers and community-based resources before we try to engage people in services in the Community Justice Support Center. And in order to do that, we are, again, engaging with community-based resources. We're making interventions available at the Community Justice Support Center in order to support people as they are working through conditions of probation that they may have to comply with. And we are also focusing on trying to enhance protective factors for people and build on their strengths so that we can put them in a good position to succeed with the interventions that are available in the Community Justice Support Center. Next slide. So this is just a quick map of the locations that we have across the state. There are 18 locations across the state. As I mentioned a minute ago, We contract with community-based providers to deliver services at the community justice support centers. So every one of the centers is anchored by a trial court employee, which is a program manager from our office, but the rest of the staff in those locations are typically staffed by community-based providers. Some of the organizations that you may be aware of are Bay State Community Services, which we work with in several locations. The Old Colony YMCA is another organization that we work with as well. Next slide. So this slide is just meant to kind of point out what we're discovering over time, and what I think the hypothesis would be in the first place is that if we're delivering these interventions in the community, are we able to lower recidivism amongst the people that we're working with? This study was initially started by the Northeastern University, and then the lab that we were working with actually moved to the University of Pennsylvania. So they picked up the study and completed it. It happened in about 2021. What they did was they looked at a group from 2013 and a group from 2018. The group in 2013, they compared people that were coming to the Community Justice Support Center with people that were just on probation as usual. What they found was that there was no statistical difference or no difference between the recidivism rates of the two groups, which is unfortunately a bad finding for my kind of career path, because I have been working in the Community Justice Support Centers my entire career. But it's intended to point out that we were trying to do good services at that point, and yet we weren't having any impact with the clients. In 2018, they looked at the clients, again, people that were coming to the Community Justice Support Center and people that weren't. And what they found was, depending on which matching technique, statistical matching technique they used, they found a 26 to 36% lower recidivism rate with the group that was engaged at the Community Justice Support Center. The difference between the 2013 and the 2018 group is really the partnership of UMass Chan, which started in 2016, and the focus that we made on making sure that we are engaging in evidence-based practices and monitoring them to ensure that we are doing that with fidelity to the design of the practices. So I guess the takeaway here is just to say something that we all know and that we all work really hard to do, is that if you follow the evidence, you follow the science, you're actually going to get the outcomes that the science is telling you that you can get. Next slide. So this is just the point here being just as a way of segueing into a presentation that Dr. Drawbridge will talk about, is that we have partnered with UMass Chan Medical School now for over 5 years, beginning in 2016 with a grant from the Bureau of Justice Assistance, but later through a contract directly with our office. And what they are doing is they're focused on making sure that there is inter-rater reliability with our risk needs assessment, making sure that treatment planning is happening effectively, and then also monitoring the cognitive behavioral groups that are happening at our community justice support centers. And they are working across all of our community justice support centers to ensure that the practice is being done with fidelity to the design, and using their teams to try the work that's being done at the community justice support centers through a collaborative approach that really builds up the skills of the people that are working in the center, rather than merely just kind of redirecting or correcting people. Next slide. So with that, I'm going to hand it over. I hope I didn't take up too much time, but I'm going to hand it over to Drs. Drawbridge and Drs. Crist to continue the presentation.
Thanks, Vin. Hi, everyone. My name is Dara Drawbridge. I'm an assistant professor at UMass Chan. So I'm going to talk now and speak about our work supporting implementation of evidence-based practices in community justice support centers. Next slide, please. Before I go further, I will be describing a project that has been implemented across the state support center. All of this work hinges on the efforts of our team presented here on the slide. This group of individuals has done and continues to do incredible work that is essential to our partnership with the Office of Community Corrections. Nothing that we speak to today gets done without them. Next slide, please. Our partnership with the OCC aims to support implementation fidelity, or the degree to which 3 specific R&R practices are implemented as they're intended to be within support centers statewide. We support implementation of risk needs assessment. These are scientifically designed instruments that measures one's functioning across a variety of life domains, all of which have been shown through research to increase the probability of recidivism. We also support implementation of individualized treatment plans, which are tailored toward an individual's specific treatment and support needs. And we support implementation of cognitive behavioral groups. So these are the three practices that we focus on. Next slide. It's important to note that our project is not a research study. It is an intentional and rigorously designed approach that aims to support and improve implementation of R&R in local support centers. And as I'll touch on today, our approach is scalable across a state system. Next slide, please. So how does the scalable approach work? We used a stepped approach. So we group support centers together into steps of about 3 to 5 sites per step. When we turn sites on in a step, sites enter a low-intensity support phase, which I'll talk more about in a moment, for an initial 12 months. If sites achieve high fidelity in risk needs assessment, treatment plans, and CBT groups during the initial 12 months, then these sites receive feedback reports and recommendations, but our active support is turned off. If implementation challenges are detected within the first 12 months, then sites with challenges enter a high-intensity support phase and continue to work with us for another 12-month period or phase 2. And we turn a new step on every 12 months over our project period. Next. So the basic idea here is that in our low-intensity phase, sites are receiving basic R&R education. We examine fidelity of the 3 practices. We develop local knowledge of factors that are affecting implementation. If sites enter phase 2, we use the work we did in phase 1 to inform the design and deployment of targeted implementation supports. As we deploy supports, we also continue to examine implementation to assess whether fidelity is improving. Next. Now, this is just an overview of our phase 1 low-intensity supports. As you can see, we provide basic education via online training. We conduct a barrier facilitator assessment via qualitative interviews and surveys. We assess the context via organizational readiness assessments. And we assess sustainability and implementation outcomes at baseline and 12 months. And we measure fidelity to our R&R practices. Next slide, please. This slide shows our measures of fidelity for each R&R practice and the benchmark we use to decide whether a site will enter phase 2 for a practice. So for risk needs assessment, we conduct a test of support center implementation quality via inter-rater reliability or the consistency between raters in scores. And we look for good to excellent agreement in their scoring. For treatment planning, we conduct a test of support center implementation responsiveness by quantifying the percent of identified client needs in treatment plans that are matched with interventions. And we look for 75% of needs to be matched over the course of programming. While not a measure of fidelity, we also conduct a test of treatment planning reach by calculating the percent of all consecutive referrals to support centers who are administered a risk need assessment and have an initial treatment plan developed. Finally, for CBT, we conduct a test of support centers' adherence and implementation quality via direct observations of facilitators delivering CBT groups in the field to measure whether they used and are proficient with essential CBT elements. And we look for moderate to high proficiency. Next, please. You can see here just a quick overview of phase 1 activities to date. Next slide, please. Now, at the end of phase 1 work, if sites have implementation challenges, they enter phase 2 and receive higher intensity support. Now, we use a process model, getting to outcomes, to guide us in the transition from phase 1 to phase 2. And we consider what fidelity challenges need to be addressed, which supports can be used to address challenges, what needs to change to implement and use the supports, and consider how implementation of supports went and did they work. Next slide. There are a number of things that make phase 2 high intensity. We design and deliver an increased number of supports at each site that enters phase 2, and the supports are customized to the specific site's fidelity needs. We also have to customize the process for implementing supports in sites because of differences in local settings. We monitor not just R&R implementation in phase 2, but we also monitor adoption and implementation of our supports. So there are increased efforts here, and all of this translates into increased complexity and emotional investment in our work. Next slide. Just to give a brief idea of the supports that we have developed for high intensity phase to date, you can see on these slides the support name, the R&R practice each support is intended for, the primary target for change, and the domain connected to the change target. Now, we use the Consolidated Framework for Implementation Research, or CFIR 2.0, as the implementation framework that primarily guides our identification of barriers. But we find that it is helpful to also use a second framework, the Theoretical Domains Framework, to really drill down further into change targets. targets, especially when barriers are connected to capability, opportunity, and motivation. So you'll see constructs from both frameworks on these as change targets on these slides. One more point, we use multiple sources of information to identify specific change targets. We do not rely on surveys and interviews only. We are also looking at the fidelity data that we're collecting in the field, and our team is having conversations in the field with practitioners to really build a comprehensive understanding of the site, and this is how we identify change targets. So on this slide, these are supports for CBT and risk needs assessment. Next. Here are some supports for risk needs assessment and treatment planning. As you can see, tools that are supporting the same practice may be addressing different domains and have different change targets. Next slide. Finally, some additional supports for treatment planning are on this slide. Next. And also here. Next slide, please. In total, we've developed 14 support strategies. 11 sites across the state have entered phase 2 work. 100% of sites entering phase 2 adopted at least one support, and on average, they're adopting 2 to 3 supports per site. 5 of the 11 sites that entered phase 2 have at this time completed phase 2 work, and 100% of these sites have achieved fidelity benchmarks by the end of phase 2. Next. Just a quick snapshot of sites to date. In the risk need assessment, treatment planning, and CBT columns, if there is a plus sign in those columns, it means that the site achieved phase 1 fidelity benchmarks, and phase 2 was not needed for that practice. But in these columns, if there was a negative sign, it means that the site had fidelity challenges for the R&R practice in the top row of the column and entered phase 2 for that practice. And the rows in green simply indicate sites that have completed phase 2 and achieved fidelity at this time. Next. Very, very briefly, because I do not have a lot of time, I want to give you a snapshot of one site profile that completed phase 1 and phase 2 work with us. In this site, the support center had 16 staff members, 7 were administering risk needs assessment, 6 were developing treatment plans, 8 were facilitating CBT groups. They served just over 300 people in the past 12 months. Next slide. The staff involved with R&R practices were on average 33 years of age with 4 years of experience in their position. However, there was a wide range of experience here. Next. We did see high organizational readiness for implementing R&R in this site. Next. When we measured fidelity of risk need assessment, treatment planning, and CBT, the site reached benchmarks for treatment planning and CBT, but fell below our benchmarks in risk need assessment. We saw poor or fair agreement in ratings on their risk need assessment when scoring overall likelihood of recidivism and in one domain that measures attitudes and behavioral patterns conducive to crime. So risk need assessment became our practice target for phase 2. Next. When we looked at fidelity data, we saw 2 primary sources of discrepancies. We did see some errors by staff when adding total domain and overall risk scores, but we also saw true discrepancies between how staff were rating the same person on individual items. This finding was supported by what we were hearing in interviews as well. 3 areas that came up as barriers specific to risk need assessment was access to knowledge and information. Staff also discussed risk need assessment scoring process as complex, noting that there are multiple sources of information that they need to use to score, and also that there wasn't always enough time and energy to administer risk needs assessments. Next. So our change targets really focused on capability and access to knowledge and information for the site. We developed 3 supports, a scoring reminder tool that summarizes in an easily accessible manner key scoring information on items, things like how constructs are defined, the look back window on items, which actually changes item to item. This was designed specifically to address true scoring discrepancies that we were seeing by reminding staff of and bringing to their attention key scoring criteria and supporting consistent decision-making in scores. We also developed a self-assessment tool, which is a short checklist of essential risk need assessment administration process guidelines. The checklist covers key process guidelines pre-administration, during administration, and post-administration. It's designed to interrupt habitual behavior. It assists staff with self-monitoring of their RNA processes, and it requires staff to check their scoring and addition. And finally, we rolled out educational sessions on risk need assessment, which offered a structured process where staff can bring questions about how to score their risk need assessment and receive information back. The site adopted all 3 of these supports. At the end of phase 2, they achieved excellent agreement across all areas of their risk need assessment measured. We also assessed acceptability, feasibility, and appropriateness of our supports. They were universally rated as satisfactory. Staff indicated they could be used successfully and were a good fit for the support center. Next slide. I am going to skip this slide just for time and just mention that I want to transition this over to Dr. Crist, my colleague and co-PI on this project. Now, as you heard from Vin at the beginning of the presentation, in our work on this project, we partnered with the OCC to embed implementation fidelity within the organization's purpose, mission, values, and guiding principles. One goal was to really ensure that the focus on evidence and implementation was intersecting positively with their values of cultural competence, trauma-informed approaches, behavior change through personal motivation, partnerships, and trust. And so I'm going to turn this over to Michelle, who will talk about our partnership on the development of a community advisory board for the support centers. Next slide, please.
Hi, my name is Michelle Crist, and like Dara said, I'm going to talk about how we integrated the voice of people with lived experience in the Massachusetts criminal legal system into program design and implementation. Next slide, please. As mentioned, we've been working with the Office of Community Corrections and support centers to support implementation and fidelity of evidence-based practices. In our partnership, Vin and his colleagues came to us with a desire to bring voices of people with lived experience in the Massachusetts criminal legal system into their approach, as there was recognition that the people who were receiving services through the support centers needed to be part of the discussion around programming and practices. We began discussing the idea of a community advisory board, or a CAB, to integrate the voices of their clients into their approach. CABs offer a structured opportunity for community members to provide information and assistance to representatives of an organization. They're often associated with clinical research and community-based participatory research, where they're used to inform research priorities and agendas. However, they can also be used to provide feedback on service delivery, where they facilitate communication between organization leaders and members of the community or clients, with the goal to improve services. This type of CAB can provide a way to tailor services to hard-to-reach populations while working to build a partnership to improve and ensure the appropriate delivery of those services. This is the primary purpose of the CAB we developed, and I'll be discussing here. Next slide, please. There are multiple benefits to establishing a community advisory board for both the organization, in this case, the support centers, and the individuals serving on the board. Benefits for organizations include building relationships with communities they serve, getting feedback to improve the organization. In our case, the support centers would receive feedback to improve services and supports for their clients, identifying practitioner and organizational support needs, and creating collaborative change. In our case, this collaborative change would benefit people involved in the criminal legal system. There are also benefits for people involved in the criminal legal system. A community advisory board provides space for people to share information about and increase awareness related to their needs. Organizational policies and programs can be shaped to be relevant to people's experiences and needs, and it provides an opportunity for members to gain professional experience. Next slide, please. Given that the OCC and support centers sit within the criminal legal system and had never implemented an initiative like a CAB, we wanted to be intentional in our approach to this work. We first formed a working group comprised of our team members at UMass Chan, OCC leadership, and managers at a few of the support centers who had expressed interest in this initiative. We held consensus building meetings that focused on the idea of establishing a CAB and the process for developing one, including the need for a CAB, what the goals of a CAB would be, and what the development of a CAB for this purpose would look like. The working group decided to start a needs assessment by surveying and holding facilitated discussions with current clients at support centers. This would help develop an understanding of client and agency needs and whether a CAB was even a viable option for assisting the support centers in better meeting the needs of its clients through the lens of the clients themselves. We surveyed 76 support center clients on what they liked about the support centers, perceived barriers to their success, thoughts about the CAB as a viable way to provide feedback to support centers and OCC leadership, and barriers and facilitators to joining a CAB. After conducting the survey, we held a facilitated discussion with clients. This was an important part of the CAB development and allowed us to gain a deeper insight into the survey findings. Overall, focus group participants supported forming a CAB as a way to inform support center programs, policies, and practices across the state. From here, we move forward into the actual design of processes, procedures, tools, and resources for the CAB, thinking about what a CAB would look like in practice. We worked with leadership to develop a variety of materials, including purpose, mission, goal, and value statements, a member description, application, and agreement, meeting rules, policies, and procedures, and recruitment materials. After designing these materials, we moved into recruitment and implementation. There were a lot of considerations in preparing for recruitment. Considering some of the concerns raised by clients during the facilitated discussion, we decided to recruit individuals who had past involvement with the criminal legal system rather than those who are actively involved. Individuals may or may not have had past involvement directly with the support centers. Since they operate as an intermediate sanction and alternative to incarceration, we also recruited people who didn't get an opportunity to participate in a support center because we believe that they offer a valued perspective on service delivery that's not often available. Next slide, please. To recruit members, we created a website with information about the CAB and a link to an online application. In total, we received 35 applicants, with 11 of them being submitted in the first 24 hours of the application being live. You can see here that 4 of our CAB members identify as male and 4 as female, 4 identify as African American, and 4 identify as white. 1 identifies as Hispanic Latino. Their ages range from 32 to 72 years old, and the majority had experience directly with the support center in their past. As mentioned, we also tried to recruit people with a wide range of experiences within the criminal legal system, and you can see there are some of those experiences that our CAB members have. Next slide, please. Impact so far. The CAB started meeting monthly in August of 2024 and has met 21 times. 14 of the 18 support centers across the state have attended meetings on a variety of topics related to service delivery. These topics have been based on survey findings, focus group discussion, and OCC leadership priorities. Through feedback, OCC leadership implemented a new group curriculum that was reviewed by the CAB. During this review process, CAB members discussed the language in the curriculum along with some of the practice examples. They offered suggestions for ways to improve the curriculum, including by revising an example scenario that the CAB members had concerns about. The discussion of this curriculum also led to improvements in training staff to use it. We also discussed support center handbooks where managers from across the centers presented these handbooks given to clients during intake. There were a lot of beneficial suggestions, including modifying language so that it felt more encouraging. And CAB members also made suggestions on where to place information and rules and regulations in the context of the handbook so that it felt more welcoming to participants as they began at the support center. All of these suggestions were incorporated into the creation of a new guidebook template that all support centers can now use. Additional topics that the CAB has covered so far are listed on the slide here that you can see, including security and drug testing protocols, how to engage, how staff can engage with participants who show up at a support center but don't know why they were referred there, addressing responsivity needs, things like that. Next slide, please. I will stop here in the interest of time, but you can see here some of the lessons that we learned along the way. And yeah, I'll stop here. Thanks.
Thanks. That's incredible work that you are doing. Thanks to Vin, Dara, and Michelle for this wonderful presentation. So I'll try to sneak in a question if that sounds good. So when implementing support across the state system, like you're describing, what are some of the things that your team does to manage work at this scale?
So first, we are really joined by an incredible team in this work, and their commitment, their attention to relationships and communication in the work that they do, as well as their competence, and their flexibility and their willingness to view the work really through the multiple lenses, but particularly the lens of the people who are doing this work. It really helps us to manage work at this scale. Really to facilitate the work and support our team, we do really pay attention to the structures around our team, and in particular, the time allocation of those who are working in the field. It's really challenging to do this work in the field all the way across the state. And so our team does need adequate time to devote to these activities. But we also use a number of tools ourselves, things like project management platforms. We use a rapid coding method as well for our qualitative interviews to really help us manage movement along the state system.
Thanks, Dara. All right, there's one other question in the Q&A, if you don't mind responding to, but I appreciate, again, incredible presentation and very thorough, and appreciate your participation today. So I will turn it over to Khoury.
Wonderful work. Thank you so much. And now it's my pleasure to introduce our final presentation of today, which will be given to us by Dr. Kim Mueser, Professor of Occupational Therapy and Psychological and Brain Sciences at the Center for Psychiatric Rehabilitation, Boston University. He's also a senior faculty member of the Center of Excellence for Psychosocial and Systemic Research at Mass General Hospital. I've had the pleasure of being mentored and working alongside Kim now for 26 years, and it is a joy to welcome him today. And he is joined by Jasen Coole, who is a mental health counselor and assistant team director for Baycove Human Services within the ACCS Adult Community Clinical Service Division, and they will be co-presenting today. Thank you.
Great. Thanks very much, Khoury, and thank you for everybody for coming to this presentation. I will be skipping a few slides along the way, but hope to really get the gist of this program across to you and some of our findings so far. Let's go on to the next slide. There are many people involved in this overall project. These are just the people at the Boston University Center for Psychiatric Rehabilitation. Susan McGurk is the project director, and I'm the co-director. Alexa Trolley-Hansen is the co-project manager and also the co-leader of the HHL groups along with Jasen. Let's go on to the next slide. And there are many other collaborators at Baycove. Of course, there's Jasen, who you have heard about, Lisa Morantanti as the vice president, and many others, too many to name here. So let's just keep going. And we want to give a funding acknowledgement that this project was supported by a grant from NIDLR, National Institute on Disability, Independent Living, and Rehabilitation Research, to the Center for Psychiatric Rehabilitation at Boston University. It is part of a larger rehabilitation and research center focused on aging in individuals with serious mental illness. Opinions and things like that expressed are not the opinions of NIDLR, of course. Next slide. So today I'm going to give you a little bit of information in terms of project background, followed by some about the development of the HHL program, the curriculum, so you can get a sense of what's in it and how it works. I'll then describe the two phases of the study, the first being a feasibility study that we've completed, and the second being a pilot randomized controlled trial that we are close to completing. Jasen will then talk about the experience of implementing the program at Baycove, and if we have any time, we'll take some questions. Next. So in terms of background, there's over 5 million older adults, and we're using the term older here, referring to older than age. I'm not sure for this particular study. It's either 50 or 60. Generally, we've used older than age 50 to refer to older individuals. But we do know that older individuals are more susceptible to chronic health conditions, older individuals with serious mental illness. Loneliness and social isolation are major problems. There is a vulnerability to being institutionalized at psychiatric hospitals or skilled nursing homes prematurely, and people are more likely to die at an earlier age. Next one. And to talk a little bit about healthy aging, the World Health Organization defines healthy aging as the process of developing and maintaining functional ability that enables well-being into older age. And so there's a number of things that older individuals benefit from in terms of skills and supports, which are necessary in terms of taking care of themselves, making their own decisions, building and maintaining relationships, managing their health needs, moving about within their environment, and feeling and belonging to a community that they can contribute to. Next slide. So the overall project and aims, and you can hit it a couple times, let's just get the whole slide out there, are to develop a group-based intervention that is aimed at enhancing social connection, health, and cognition in people with serious mental illness. It's the combination of these three goals that makes this program unique. First part of the project involved a feasibility open trial, and the second part is involved a pilot randomized controlled trial. All that is done has been done in partnership with Baycove Human Services. So let's go on to the next slide. And we addressed a number of research questions. The research questions for the first phase, which is the feasibility trial, are essentially, is it feasible to implement a group-based program aimed at enhancing cognition, social connection, and lifestyle behaviors. And by feasibility, we mean, is it acceptable? In other words, are participants in the program satisfied with it? Is it appropriate? How well does it seem to meet participant goals? How much do participants benefit? And is it feasible? Will participants come to the group? Will they complete the program? And then phase two was the randomized controlled trial, where the goal is to evaluate whether participation in the HHL program is associated with increases in perceived social support and decreased loneliness, improvements in cognition, or reductions in decline in cognition, increased healthy lifestyle behaviors, and improved psychosocial functioning. Let's go on to the next slide. And project timeline, it started in 2024. It's going to be ending early next year. And that's all we need to say about that one. And to talk a little bit about assessments, in the feasibility open trial, we did basic assessments of outcomes. And then we also conducted semi-structured interviews with participants who completed at least 50% of the HHL classes in order to evaluate acceptability, appropriateness, and feasibility. And then the randomized controlled trial involves assessments at baseline, post-treatment, 4 months later, 4 months after that, or an 8-month after the baseline assessment, and a 12-month post-randomization assessment. And these assessments include semi-structured interviews with about half of the experimental group participants and 10 Baycove leaders to identify facilitators and barriers to the implementation. The core assessments include outcomes such as cognition, social connectedness, and the like. Let's go on to the next one. And I think we can skip the data analysis methods for now. And so let's talk a little bit about the development. The development of the program drew from two evidence-based practices for people with serious mental illness. The class structure and the skills training components of the program were drawn from a program called Helping Older People Experience Success, HOPES, a program developed by Sarah Pratt and myself and Steve Bartels a number of years ago that has a very strong evidence for improving psychosocial functioning over the course of a 1-year group-based intervention, primarily focused on skills training, but also that integrates nursing care. And then the second practice is cognitive self-management strategies, which are incorporated. They're taught throughout the HHL program. And that is drawn from the Thinking Skills for Work program, as developed by Susan McGurk and myself. And that has over 6 randomized controlled trials showing that it both improves cognitive functioning and improves work outcomes in people with serious mental illness. Let's go on to the next slide. So this is an overall kind of conceptualization of the approach. So the Hopeful and Healthy Living intervention is aimed at enhancing the capacity of people in terms of their social skills, and in terms of their cognitive functioning, their cognitive abilities. And that leads to both social skills and cognitive skills being integrated into all of the different sessions in the program. The sessions thematically are organized around three different areas: healthy lifestyle routines, enhancing social connection, and health, illness management, and cognitive related management in there as well. And these together are supposed to produce the outcomes of healthier aging. Let's go on to the next one. So HHL classes, there's 16 weekly classes. They last about 90 minutes each. They're co-facilitated by Alexa and Jasen. They have been the co-facilitators in the group thus far. Although we have also offered the group at the Recovery Center at Boston University over the summers. And then handouts are provided for students in a binder. And the basic structure of sessions is that it begins with a welcome. There's then a review of the action plans or home assignments that individuals do. That's then followed by a warm-up activity. There's then a discussion about the class topic, and not just discussion, but also like role plays, practice, and things like that. There's then a movement break, which is done to music, quite a bit of fun for everybody involved. There's then some skills teaching, some skills practice, and development of an action plan. Let's go on to the next one. And this looks a little complicated. We don't have to go into too much detail, but this is actually an outline of all the 16 sessions. And if you were to read specifically, you'd see each session includes some information about social skills and some information about cognitive self-management strategies. And they are organized in terms of these themes: healthy aging, social connection, healthy lifestyle activities, and leisure. And you can see under each one, there's a number of different kind of topics, like the class 2 is recognizing your strengths. And it involves the cognitive strategies of using personal strengths to develop a goal, and then the social skills of how to share the goal with other people. But it's a very curriculum and skills-based intervention aimed, again, at wedding these three important contributions to healthy aging of social connection, healthy lifestyle, and a cognitive health. Let's go on to the next one. The goals of the group, of course, are to be active and engaging. Each individual sets goals at the beginning of the program. Warm-up activities include things such as trivia games, group brainstorming activities, team-based activities. Different topics are introduced through a discussion process, with then practice coming later. I've mentioned the movement break. Skills are modeled and then actively practiced, as in typical skills training approaches. Action plans are developed collaboratively with students. And we call these classes rather than a group therapy thing. It's a kind of a normalizing effect. And we like to provide light snacks and coffee and tea as well. Next one. So here's an example of a warm-up activity from class 3. And this is the aging beliefs trivia. And so what we do is we kind of go through these. We get people to rate them. Either we have it on a piece of paper, or people can do it verbally as well. But how many people believe these, and how much? And we use this as a way of stimulating discussion. Hey, older people can't learn new things, or more life experiences makes you wiser, and so on. And these are all what we would consider to be common myths that people have about aging. It is a kind of a warm-up discussion, in part to challenging these kind of myths that you can't change, that you can't learn new things, including healthier lifestyle behaviors. Let's go on to the next one. So these are the results of the open feasibility trial. The open feasibility trial was conducted in a residential setting, Walnut House, at Baycove, whereas as you'll see, the controlled trial has been conducted at 2 of the clubhouses of Baycove. The open feasibility trial involved 8 participants, mean age of 67. Majority were men, majority were African American, and the majority had either schizophrenia or schizoaffective disorder. One person dropped out due to hospitalization. There were very high rates of participation in the class. We did have difficulty getting people to follow through on action plans, but in general, there were high rates of retention in research overall, supporting the general feasibility of the program. Let's go on to the next one. These are results, and I won't go into them in a lot of detail, but we did look at outcomes, and rather than doing statistical analyses on 8 people, we just looked at the percent who improved. 71% reported improvements in social support, 88% in loneliness. No, I'm sorry, only I think 12%. There were not changes in loneliness over the treatment period. There were changes in cognition. And then in terms of healthy behaviors, we saw some improvements in both healthy eating and physical activity. And we also saw some improvements in psychosocial functioning as well. Go on to the next one. Perhaps more importantly, given the small sample size, we got there's a couple of more examples, I believe, on this slide. If you advance it 2 more times. Keep going. Thank you. And back one. There was lots of positive feedback from participants in the group. One participant said it was intriguing. I didn't know what we were going to do next. These are all hopeful. They're all part of hopeful, healthy living. And another participant said, "I look forward to every Wednesday, healthy or not. I looked forward to it. It was a joy being there." And yet one other person said, "I kind of enjoyed that class. Nothing much happens around here, but I did enjoy that class." So I won't go on, but in general, the results certainly supported the feasibility, including acceptability and appropriateness of the intervention. Let's go on to the next one. We did a number of modifications after this feasibility trial. We replaced the outcome measure for physical activity to one that could be applied more broadly. We created more facilitation strategies to promote completion of the home action plans. We updated participant handouts to highlight skills that we learned. And we tweaked activities in a number of classes based on participant responses and facilitator feedback. Let's go on to the next one. And just you can tap it. Let's try one more. Go backwards. Thanks. So we have actually completed recruitment. We recruited 64 participants, and 60 people were randomized to either the HHL class or treatment as usual. These groups have taken place at 2 clubhouses operated by Baycove. We've actually completed all of the cohorts, all of the groups at each of the different clubhouses, and we're now conducting follow-up assessments. We have not analyzed the data yet because the final assessments are supposed to be collected in the fall of this year. We've been doing semi-structured interviews and data analysis. In terms of the qualitative interviews, we've already assessed, I believe, 14 out of 15 participants and 9 out of 10 staff members. We can go on. And so far, in the randomized controlled trial, we have seen, if you don't even count makeup sessions, we do try to have makeup sessions for people who can't make a particular session, but the attendance rate has been an astounding 81.5% across these 2 different clubhouses for participants in the HHL group. And that's really an excellent rate of attendance for any population, much less a somewhat older population. And then, as I indicated, we do try to provide makeup sessions for people who missed a session. And if you include those, you're up to almost a 95% rate of attendance at the groups, which is it's probably just about the highest that I have seen personally. The preliminary qualitative results that examine barriers and facilitators to implementation indicate that facilitators are the people who really enjoy doing the HHL group, and staff members have found that it helps clients and themselves. Barriers, one barrier that's been identified is that it's not yet available in Spanish, and I suppose it's always good when a barrier to an intervention is the fact that it's not available in more languages. And staff have spoken about the need for staff training and funding to support the sustainability of the program. Let's go on to the next one. So at this point, I am happy to turn it over to Jasen, who is from Baycove, has co-facilitated all the groups. He's been an invaluable a partner of our overall research team and connection with Baycove. And he's going to just talk a little bit about the experience of implementing HHL at Baycove, after which, if we have any time, we'll take some questions.
Thank you, Ken. First, I'd like to say that it's been a privilege working on this project with BU and the Center for Psychiatric Rehabilitation. So like Kim mentioned, we began this project with our clubhouses, which was very exciting. And we did open kind of community forums to gauge interest. And it was overwhelming with the amount of participation that people wanted to be involved and the interest shown. The main things that we saw progress on were in social interactions, the activities related to movement and music, which was a nice little break in the middle. But what was great about that is that we were able to tailor the music to a specific age around, late teens, 20s. So we tried to pick music from the time period that these folks would have been younger. Kind of a helpful therapeutic tool to bring back better days in a way. It was interesting implementing empathy too, as well, teaching folks more empathetic skills and tools on ways of engaging and interacting with each other, which included topics like small talk, which was eye-opening at how easy it was to get our folks to start to engage by implementing these strategies and tools for them. There has been a great continued interest with our clinicians and our community served, our persons served. They keep asking me if I'm running the class solo or if there'd be continuous classes. There are clinicians involved. This interested as well. This project primarily focused on our individuals in the community. And I know there is a need and a want for it in our GLEs. And with time, I'm hoping that we can, as an organization, start implementing this group in all aspects of our service. But I think, Kim, unless you'd like me to.
If that's I really appreciate your contributions, observations. We are entering a very interesting phase with Baycove in which we are now beginning to explore sustainability of the program at Baycove and things that we can do to support that. Your continued involvement in the project, Jasen, is very much appreciated. Why don't we take the opportunity to stop and see if people have any questions about the program?
Fantastic. Thanks so much, Jasen and Kim. So let's start with this question. How was the group advertised for consumers? Did treatment teams refer participants to group, or did consumers self-refer?
So Jasen, you're obviously in a great position to respond to this, but if you would talk mostly about the implementation of it at the clubhouses for the RCT, which is where we, have done most of the project, that would be great.
So yes, we had an open forum. Basically, we advertised the group that it was something that we'd be promoting, and we, Alexa and I, the other co-facilitator, met at each of the clubhouses to explain the project and to gain interest. And we did 2 of those sessions before we began each cohort. And of course, with demand as well, some had to wait for the next cohort. And we're still seeing it. People are still asking and demanding. So it's not a referral base. It was kind of open forum and at will.
And there was also some advertising of the nature of the group to medical teams and the like, although it wasn't referral based, as you said. But that is that correct?
Correct. Yes. Within our programs, we were letting staff know and encouraging staff to answer questions, and informed other staff and peer leaders and coordinators as well of the project to spread the news around. And our team on the clinical side too was encouraging our folks out in the community to engage.
Fantastic. And I guess on the question of sustainability, one question here. Have you explored having Clubhouse members co-lead the Hopeful Healthy Aging classes?
Not yet. Not on my end, but Kim, I don't know what happens at the center.
Right. Well, interestingly, at the Center for Psych Rehab at the Recovery Center, we have had some peers serve as co-leaders along with other co-leaders, and so we have some experience with that. I think that this will come up in our discussions with people at Baycove. Certainly having a peer co-leader along with an experienced leader would be a great benefit and probably improve the feasibility of making it a sustainable service.
The benefits I've seen, I think this would benefit any community-based program. It's been amazing to see the want and excitement and need for continued classes and the excitement to come back. And even our person serve that I see in the community or out and around our building, they will say, "Hey, when's it coming back? Still doing my homework." So that's been great. And it's been really heartwarming too, to see that they're continuing to open their workbooks and wanting to work on continuing to build themselves and work on themselves. It's been wonderful.
Amazing. Do you think this group is appropriate only for older individuals? What do you think do you think younger ones might benefit as well?
Well, that's such a great question to ask, Khoury, because at this very moment, we are in the process of modifying the curriculum for the summer semester of the Recovery Center at the BU Center. For people who don't know, the Recovery Center at the BU Center for Psych Rehab offers a wide range of different psychiatric rehabilitation classes, kind of in the format of classes, but with practice and things like that each semester, and including the summer semester. And we did offer it last summer. And this summer, Dory Hutchinson, the director of the center, said, there's a lot of interest in this program, but younger people are interested. They want to get in. And of course, you can never be too young to begin living a healthier lifestyle, connecting more closely with others in your community, improving your cognitive abilities and the like. And so we are, in fact, modifying the curriculum to make it non-age specific. I think that there's a particular appeal when you have a group of older individuals together in terms of the nature of the shared experiences and everything. But the truth of the matter is the things that we're trying to enhance would probably benefit all the more if you could enhance them at an earlier age.
That's great. I have a question that I'd like to add. Can you speak a little bit, because this strikes me as quite unique, to take psychosocial rehabilitation of this nature and bring it into a clubhouse setting. Can you talk a little bit about that and what the implications for, the amazing reception to this sort of work has been?
Sure. Jasen, do you want to take a stab at it or should I?
No, I can. I and maybe with your assist, Kim. I do think, like one of those comments said in one of the slides, that there's nothing to do around here. We're constantly looking for ways of mitigating loneliness and depression in our older folks and keeping them engaged. And we offer outside activities. There is work placement opportunities and all kinds of things related to being productive. There's not a lot about skills-based learning. Some of that's funding as well, right? There's just not enough money to go around sometimes. But I think with this interest and the renewed excitement, I think it's something new and exciting, and it gets folks engaged in a way that they haven't been. Unfortunately, a lot of groups don't happen in these community settings. So.
Right. Preliminary discussions that we've had with our colleagues at Baycove have indicated that there is some reconsideration of the role of groups in psychiatric rehabilitation there in the agency. And so I think that this very positive experience in a traditional clubhouse setting may potentially open up some doors in terms of broadening the programming. We know that clubhouses traditionally and to this day have a strong focus on work. But there's something to be said for health and healthy aging, and its role in supporting work and productive contributions that people can make to their communities.
So wonderful. Thank you so much. And there's one remaining question. It's kind of a big question in the chat. If you can try to respond to that, that would be much appreciated as well. Thank you, Jasen. Thank you so much, Kim. Really appreciate this presentation and look forward to seeing the results of the randomized controlled trial.
Great. Thank you.
Thank you very much.
Fantastic. So, as I reflect on today, one of the things that comes to mind is that our title was very apt. So our title was Building Solutions and Breaking Barriers, Advancing Behavioral Health Through Community Collaborations. And I do think that what we've heard today really brought this to life. And, just to contrast it with the typical long-standing research model of researchers, experts coming together, defining a problem, and designing a solution and testing it. I think what we've heard today really reflects quite a different model. Across every presentation, there was a consistent commitment to starting with listening and listening to staff, listening to people with lived experience, and listening to community partners. And importantly, using those perspectives to shape the work really from the beginning. I think in the work of tackling making inpatient units safer places to work, safer places to rehabilitate and heal, it was very clear. The process began with structured listening sessions across multiple hospitals to understand really what was happening. And what we saw were meaningful results, substantial reductions in aggression and assaults without a rise, and in fact, in some places, a decrease in seclusion and restraint. In the community corrections work, we saw the same principle, centering partnership, trust, and lived experience through community advisory boards that directly inform the programs and policies. And the amazing support, of course, of the iSPARC Technical Assistance Center to make sure things were done at a high fidelity to the model. In the SMI REACH project, we saw listening at scale, that has just started, but bringing together agencies, providers, and communities to understand where the systems break down and really co-develop solutions. And in the Hopeful Healthy Living program, we really saw an intervention that was designed with participant input. And then we saw how well it was received when you design things to be in line with what people want. Maybe it's not surprising that you get great attendance and people clamoring for more. So taken together, I think that these projects, the work today really highlights that listening isn't just a step in the process. It's really an innovation strategy, and one that we are using more and more in our work together. It really requires, collaboration and humility and being open to thinking we don't already know the answer and questioning everything. I loved the flashlight example that one of the staff brought up today. That probably has been happening for decades, that night checks were done with a flashlight. And what a wonderful example of listening to people to offer an alternative. So I think these are meaningful changes that make changes in people's lives and in the systems that serve them. And it also shows how hard everyone is working to change things. And to collaborate together, and how much psychology is involved in change for all of us, the people we serve, but all of us were involved in these systems. So I think I learned from today and that incremental science is an iterative process. It's built through partnerships, and it's strongest when we continue to learn from each other and from the communities that we serve. I want to close with incredible gratitude to all of the presenters. Thank you for sharing your work so thoughtfully. To our partners at Department of Mental Health, thank you for your collaboration and support. To the clinicians, staff, and community members who contributed their perspectives, to everyone with lived experience, not just people with experience of mental health challenges, but people with lived experience of working in these spheres. And also, of course, I like to thank the interpreters very much, and all of the ways that UMass helps us make this work very accessible to all. It's a privilege to be part of this community and this shared effort to improve behavioral health care across Massachusetts. I'll turn it to you, Megan.
Thanks, Khoury. It's a pleasure to provide some thoughts as we wrap up today's conference. First, it's been a privilege to serve as the director of iSPARC and co-lead this event alongside our outstanding partners at MGH's COE. Thank you for hosting such an excellent event today. And today we heard about multi-level barriers in behavioral health systems, from the experience of stigma and access from the people with lived experience and their perspective, to provider perspectives on the need for training and maintaining the continuity of care. And we learned that when offered, 90% of patients will accept effective treatment, which highlights the importance of provider training and equitable access to behavioral health services. Another theme that we heard today was the importance of community engagement, including the perspectives of people with lived experience and providers in the design and the evaluation of our service and our process improvements. Including these voices improves the chances that projects or solutions will be widely accepted and that these solutions will be effective. I'm especially grateful for the honest and meaningful conversations that we had today and that took place in the middle of these projects, like the facilitated listening sessions. It elevates the voices of the people that are directly involved in providing services and those who receive them. As a behavioral health community, we are committed to making sure that there are effective and accessible services that are available across the care continuum. Thank you to all of our presenters, panelists, and you, the attendees, and everyone who contributed to this event today for your dedication, for your questions, and for your willingness to share and learn. And I'm hoping that we can carry forward our momentum from today's conference. We can implement some of these new strategies we learned about today in our work, and also continue to advocate for comprehensive evidence-based care. So thanks for that opportunity. All right, we have a slide, if it's possible to bring up, just to highlight again our technical assistance work. Oh, I guess it's not here.
It is. If you go forward a little bit more, and then we can go back. Perfect.
Okay, perfect. Great. All right. So just highlighting this again, this is our website, a snapshot of our website. iSPARC helps the Massachusetts DMH workforce with any technical assistance needs by providing information based on research. And Dr. Marsha Ellison had mentioned this today. So we wanted to show you the website. We can provide expertise and information on a wide range of mental health related topics. We can provide basic technical assistance like tip sheets or brief phone consultation if you need it at no cost, and we can also provide more intensive technical assistance like policy development and training, like things that you heard about today, in collaboration with DMH approval. So please check out our website for more information and enter a request. Here is a QR code on this slide if you want to go directly to our website, and then it's also in the chat. The link is there in the chat as well. So thank you. All right, I'll turn it back to Khoury.
Excellent. And if we could just go back a little bit, I'm just going to give you all a chance to scan this QR code for the evaluation form, which we would absolutely love if as many people as possible here today could complete the evaluation form. It should only take a few minutes. We take this very seriously. We summarize this information comprehensively. We review it with DMH. And so it would really help us to think about how to gear the conferences to be, in something that you want to hear about for next year, because we will do this. We do this every year. There's also a link here. Maybe we can put the link in the chat for people who didn't have a chance to grab the QR code. And then, yes, please go ahead to the next one. So what you will see is that the evaluation requires you to register for the MGH Psych Academy. That's because they have helped us set up the certificates on their learning management system. So to do that, you need to log in and create an account. So if you already have an account, you just log in. If you need to create an account, you create one. If you're an MGB employee, you probably already have one. And then you will see this course, which is the course that you are enrolled in by saying take course, and you will do the evaluation and then get credit and your certificate. So if you have any questions about that, you can certainly email us. You can email myself, and I'll be happy to help you with it. We can put my email into the chat as well. We also look like we might be ending a couple minutes early, so maybe you have time to actually do that evaluation now, which would be wonderful. We want to thank you all. We want to thank you for your incredible engagement today and for the work that you do every day. Know that it is important and that it is changing lives. Pleasure to be with you all today, and pleasure to do this with my colleagues at iSPARC.